Chair Kelly, we're live and ready to go.
Okay. Good afternoon, everyone. We're here for very, very important business today. Senate Finance Committee and the President Pro Tem of the Senate, who also chairs the applicable subcommittee for the Budget and Taxation Committee. We want to welcome everybody and to suggest to you that we have so many very highly expert speakers, some who provide services, some who administer services, some who are supposed to make sure that services are paid for in a timely and fair way, and others, some of us who might need services, considering the impact of this pandemic and the extent to which citizens, residents, visitors of all stripes are finding themselves in a state of public health need and in a state of depression and despair. So we are fortunate today to have available to us persons who represent both the provider community, the administrative community, the policymakers from the Maryland Department of Health, and experts who simply know public health up and down as a result of their academic and professional backgrounds. Since there are so many of us, before I call on Senator Griffith, representing Budget and Tax, I would like to suggest that if we on the committees would try to talk less today and to listen more, because there's so much and so many important people to listen to, so many sides to all of these issues. They're not simple, they're very complex issues. We can continue to unpack later and to decide how we need to respond. So at this time, I'm going to call on the President Pro Tem of the Senate, who chairs the relevant subcommittee in Budget and Tax, for opening remarks.
Thank you, Madam Chair Kelly, and thank you to the members of the Senate Finance Committee for inviting the Health and Human Services Subcommittee to join you in your hearing today. Our Chair, Guy Gazzone, and the members of the Health and Human Services Subcommittee were met very early on in session with the issue that this hearing is seeking to address. We started the 2020 session with questions about the process that allowed this situation to come to fruition. We asked ourselves how this system went live in January of 2020. And, you know, basically at that time, the decisions that were made to kind of remedy the issues, we had no idea that 7 months later, we would still be grappling with this issue. I don't think anyone did. We certainly want to applaud Secretary Neal and his team, who have been working probably without sleep since we left each other in March. And I know we've seen one another in many meetings over the months, and they've been working to keep our state safe. But we do have to resolve these issues so that we don't continue to have these challenges in the months and years to come. And so we look forward to hearing from those, Madam Chair, that you've scheduled to present to us. And we've heard your feedback about keeping our questions and remarks to a minimum so that we can hear from those that you've brought together today. We do and will have some follow-up questions, but with that, we certainly again want to thank you. I see 3 of our subcommittee members here, and just thank you all for being here, and we look forward to today's information and getting some of these important questions that we all have answered.
Thank you very much. We have, I think, about 22 experts, and everybody's an expert from their perspective and given their job title. And we're going to start with those experts from the department, the secretary. And we want to say, before we get into the business, how sorry we are going to be to see you leaving for retirement, Mr. Secretary. And you've been with us on both sides of the aisle and in both houses as one of our colleagues, as well as our public health leader. And so we wish you well as you go into the sunset and hope you have fun while we're working hard in session. We're going to start with a panel from the department dealing with the optimum issue. You know, the ASO was changed from what we had traditionally had for mental health. And we've had a lot of problems, and we're going to learn more now about the scope of the problems, both from the perspective of the department and from the perspective of the provider panel, and to see what recommendations there are for us moving forward in a way that's orderly and helpful. So we'll start with Secretary Neal, and he will be followed by Chad Burkholder, Chief Operating Officer for Optum Behavioral Health, Dennis Schrader, Chief Operating Officer for the department, and Dr. Aya Jones, Deputy Secretary.
Thank you, Madam Chair, members of the committees. It's my pleasure to be here, actually for the last time, I think. Thank you for having the Maryland Department of Health and Optum Behavioral Health here today. Our goal has been to ensure that the 200,000 Maryland Medicaid beneficiaries who receive behavioral health care are able to receive these needed services and to ensure access to a robust and quality public behavioral health provider network. Grants to fee-for-service transition. Over the past 10 years, through both this administration and the previous one, and through multiple General Assembly sessions, the Maryland Department of Health has been steadily directed to transition the state's public behavioral health financing system from a grants-based system where a provider is simply handed a lump sum of cash to a fee-for-service system where providers are paid for services directly provided to individual clients, just like a visit to any other healthcare provider like your doctor. Three basic reasons for that. Fee-for-service ensures fiscal accountability. The federal and state taxpayer know what they're getting and know who is getting these services. Quality health care measure tracking through individual outcomes, and leveraging Medicaid to gain federal matching funds and expand the number of providers through any willing provider. Beacon to Optum. Maryland's previous administrative services organization vendor, which handled claims and from providers, reviewed the claims and paid the claims, Beacon Health Options, their contract ended at the end of 2019. We competitively bid for the next 5 years and received two bids, one from Beacon and one from Optum. Beacon's bid, which was $50 million more over 5 years, offered us less than Optum, and we subsequently found out had some technical issues and poor documentation as well. The contract's parameters included parameters from the recent Department of Legislative Services budget analysis, which identified areas where increased oversight and cost controls could be implemented. And we wanted those in that contract. Optum's bid was recommended, reviewed with unanimous approval by the Board of Public Works in July of 2019. In September, Optum and Beacon began a rocky transition through the fall and winter that largely resulted in Optum having to reconstruct an insurance system from scratch. As a side note, they're still having to clean up Beacon's data from the end of last year. As a result, Optum had a less than successful launch in 2020. Estimated payments, the first half of 2020. I directed Optum to begin estimated payments in January through the beginning of August based upon the provider's historical average payments in 2019. Maryland paid out slightly over $1 billion in 8 months to about 2,200 behavioral health providers. This had an unplanned benefit of providing a stable cash flow during the most restrictive months of the spring COVID-19 shutdown to providers. However, providers have been required to submit claims for actual services rendered during this period, and as we will discuss later, will result in the reconciliation and return of up to $163 million to the state due to our overpayment. We hope to work with providers on reconciliation through the remainder of this fiscal year in order to provide budget certainty to the General Assembly in fiscal year 2022. Next slide, please. System reactivation, July 2020. Optum has worked diligently to bring their system online in July, and they have been actively processing claims since. Their system is not perfect, but it has seen steady improvements since July, and as the technical teams listen and learn from providers. Since the end of estimated payments in August, Optum's system has processed and paid out over $453 million in payments and an weekly average of $32 million, which is pretty much in line with historical trends. I would add that we have daily progress reports and have since the middle of the summer. So there are a lot of eyes on this, and we're trying to make it better. So what's next? Provider service improvements to the new claims processing system, which Chad Burkholder, the Chief Operating Officer of Optum Behavioral Health, will describe in just a moment. We'll have a more detailed walkthrough of the reconciliation process by the Department of Health's Chief Operating Officer, Dennis Schrader. And then we'll have a brief discussion of our provider outreach efforts by Dr. Aaliyah Jones, who's the Deputy Secretary of Behavioral Health. With that, I will turn it over to Chad Burkholder. Thank you all very much.
Thank you, Mr. Secretary, and thank you, Madam Chair Kelly, Madam Chair Griffith, and the committee. I appreciate the opportunity to come and talk about the work that we have been pursuing. I'm going to address 4 key areas in my opening remarks. First, and most importantly, is I want to convey that Optum is very frustrated and disappointed with how this implementation has gone. The launch was extremely complex, but frankly, even acknowledging the complexity, the launch performance was unacceptable. We accept that, and we have been, and will continue to be committed to getting this right. That is overwhelmingly a message I hope that the committee hears, is we're committed and we're engaged to make sure we get this where it needs to be. Second, I'll touch on claims performance, and while that's improved exponentially since relaunch, we recognize that ongoing improvements are urgently needed, and they are underway, and we're engaged with both the department as well as our provider partners to drive that. I'll address authorization performance. This has largely been has performed effectively since July and has supported appropriate access to care. There have been some pockets of slower authorization response times, but they've been very, very limited. And then I'll address the customer service performance of Optum. This has not met my standards or the standards of our leadership team, and we've taken some very important steps over the last 6 weeks to improve performance, and we'll talk about that. You can go to the next slide, please. As Secretary Neal noted and as reflected here, we believe the biggest indicator of our system's performance is that since relaunch, we've paid out more than $453 million to providers and an average of around $32 million a week. And also, as Secretary Neal noted, that is very much in alignment with historical outcomes. You can go to the next slide, please. As far as timeliness of payments, we've also seen strong improvement month over month. And while not reflected on this slide, the month of November is now reporting into the mid-95, 96% range in terms of claims adjudicated within 14 days. This is an area where we're pleased with where inventories are being managed today, and we think that is leading to urgent and timely payment of claims to the providers. You could go to the next slide, please. Claims denials have been especially frustrating to providers and, frankly, to Optum as well. And there's been a mixture of drivers. These include systematic issues, but largely denial rate has been driven by the accurate application of state policy and even by provider submission irregularities. And we're working very actively with providers on addressing those irregularities. The claims denial rate currently is at 13.7% now, coming towards the end of November. This is a strong improvement over where it had been. Over the past 6 months prior to relaunch, it was in the 21% range. And since relaunch, it's at a combined roughly 15% denial rate since the relaunch in July and August, as the Secretary outlined. The denial rates under the previous vendor were at 13%. So we're right in the neighborhood of where the historical results have been. Now, Optum has been working very actively to engage with the providers themselves very directly, and frankly, I'm appreciative some of those providers are represented here today and their teams, and they've been very engaged and very supportive of having the kinds of conversations that get us to solutions. We've also been able to examine issues relative to submission practices, and the providers have also really helped us better understand how the tool can be reconfigured to improve, whether that be because of systematic issue or whether it be because of a configuration preference, and we appreciate their engagement. Throughout the year, providers have also been very frustrated by a significant number of claims being reprocessed due to errors being corrected. And we've seen significant improvement in this performance since the relaunch. Today, reprocessed claims represent only 7% of our overall current inventory. And that number is not alarming, but has been improving, and I suspect it will improve further. Providers have questioned whether or not current payments are driven by aged claims inventory, and I'm glad to report that over the past 5 weeks, we've broken claims payments into 2 parts. The weekly payment is driven by new claims processing, and that's been averaging roughly $32 million a week. And in addition to that, we've been reprocessing any legacy claims and been using those to offset any of the impacts related to estimated payments. And claims payment accuracy is also a critical measure, and we've been working very actively to make sure that data challenges and system configuration challenges are improved so that we improve our overall claims accuracy. We've seen significant improvement, but there's still more work to be done, especially for large providers and hospitals, and we're working actively to address those needs. If you could go to the next slide, please. From an authorization perspective, our volumes that have been processed are very consistent with historical levels. And 97% of all authorizations have been received directly through the electronic portal, and 97% of those of all of the authorizations received are being processed within the turnaround time requirements dictated by the state. And we're working very actively to make sure that that stays stable. We have seen 5 specific days since the relaunch where the turnaround time fell below standards, and we immediately addressed those challenges, and we've seen very strong performance in the very high 90%, 98, 99% range in terms of things being processed, authorizations being processed within the target timelines. Let me close my comments also by addressing customer service experience. We absolutely recognize that the service to providers has been unacceptable. Frankly, Optum underestimated the complexity of the service model, and we leveraged an external vendor to support the customer service function. I absolutely acknowledge that this was a mistake, and we recently decided to move all service back inside of Optum's Enterprise Service Center. This is going to drive much more direct accountability with my team and also more control. And this transition is beginning right now, and will continue in December and be completed by the end of February. But we are already and will continue to see significant improvements related to customer service outcomes. We also realigned accountability for managing the service functions and specifically the vendor performance. Over the past 6 weeks, we've seen strong improvement as we've tightened our management of the customer service vendor. Over this time, we've seen a significant reduction in daily call volume, and we've also seen a significant reduction in the number of daily escalations. In fact, our escalations volume is down 29% over the past 6 weeks. And our email box that manages the provider relations workload is actually down 94%, and we believe that we're in a good position to sustain more effective, timely response to providers They certainly deserve it. We're working hard to make sure that that happens. To close, I just want to reiterate that I, one, am very frustrated on behalf of my team, on behalf of Optum, and certainly we're frustrated for providers with how things have gone throughout the year. I want to reiterate how committed we are to getting this right. We're going to work hard with our partners, both at MDH and the provider community, to get this right. And while we've seen exponential improvements, we do know that specific providers are still feeling pain of specific issues, and we're dedicated to getting those right. I'm going to turn things over now to Dennis Schrader, MDH Chief Operating Officer, and he'll go through the assisted reconciliation process details.
Thank you, Chad. Madam Chair and members of the two committees, if I could have the next slide, please. As the Secretary mentioned, we have paid out over $1 billion in estimated payments from January to August 3rd. And in that, we have about $894 million of total payments and authorized claims. And we estimate that as part of the reconciliation, there may be about $163 million owed to the state. But that will be a process that we will go through to determine, where that number actually is. But that's our best estimate to date. And the bottom line is we're required to do this by the federal government as a condition of them giving us matching funds and to ensure that our state program integrity complies with the Inspector General and the legislative auditors. If I can go to the next slide, please. We have heard loud and clear from the providers over the last 3 months that they need help with this reconciliation process, and we have determined that the best way to do this is to create what we're calling an assisted reconciliation process, and that'll begin December 1st. Once all the documents that they need are going out and will be finished before the end of this month, and that process of assisted reconciliation will go from December to May of next year, and it'll enable providers to focus on reconciling their accounts receivable and for us to understand and resolve open issues and defects, and if they need additional resources, what those might be and how we might be able to help. Based on the information gathered from the providers, we will confirm when the actual final reconciliation will be after we go through this 6-month period. And I'll also want to emphasize that there will be no recoupment from the providers until we go through that process. So we are allowing plenty of time so that the providers are not under duress and stress in this already stressful period for this process. I want to mention the fact that we have established reconciliation managers that are an individual that they get to know and work with directly as a reconciliation manager. So far, over 1,000 providers have responded to requests to have a reconciliation manager, and thus far we've had about over 200 reconciliation meetings with providers. Our goal is to make this process as efficient and effective as possible, and we will continue listening to the providers as we go through this process to make sure that they are helped to get through it as we try to figure out how much final money is owed to the department and the state. Next, I want to pass it on to Dr. Aaliyah Jones, our Deputy Secretary of Behavioral Health Administration.
Thank you, Dennis, and thank you for having us here this afternoon. At the end of the day, we want to make sure that everyone who is able to receive behavioral health services in the state of Maryland has access to those services, particularly now during these difficult times. We're actively monitoring all of our inquiries from the community to ensure that those in need, either through the state's crisis hotline, through our local crisis call centers, through health providers, that they're able to access quality behavioral health services. At the same time, we continue to provide many forums for the provider community to communicate with us and share their concerns, brainstorm solutions, share their best practices with one another, with the MDH staff and our Optum partners. Provider outreach has been extensive and has included many training meetings hosted by Optum's Provider Relations, up to 180 or more. WebEx training sessions that have been attended by over 2,600 provider staff, of which there have been 47. Provider council meetings, which occur on a monthly basis, of which there have been 4. And weekly operation improvement committee meetings, which we've had 14 of over the past several months. We look forward to Optum's system improvements over the next several months and toward partnering with all of our stakeholders as we develop and implement much-needed service quality and system of care improvement measures. For more information, I do refer you to some of our briefing materials, including our Optum fact sheet and our Joint Chairman's report. And at this time, we are happy to take any questions that you all might have. Thank you.
Okay. Are there any pressing questions at this point in time, colleagues?
Madam Chair,
Yes.
if I could just jump in, I know that you have other presentations and I don't want to hold up the hearing, but I did want to ask the secretary and his team if they could follow up with me on a couple of things. The first is that I'm hoping to get information on the overpayment detail, hoping they can provide it by provider type and percentage of individual provider revenue. The second thing is, having looked at the Joint Chairman's report, I wasn't clear if it was made up of unique providers or if it was a duplicated count. And the third, I think it was Mr. Schrader on page 8 of the MDH slides talked about the projected timeline. And I'm hoping to hear back from them about the recoupment remedy. I know that they have planned that for the spring and early summer, but my concern or my ask is we'll be reconvening in January, and it would be helpful for us if we could be engaged in that conversation while we're still in session. Looking at this slide, it looks like your timeline for dealing with the recoupment and reconciliation plans would happen after we likely adjourned in the spring. So I just wanted to get those items, Madam Chair, on the record and hope to hear back from someone on those. Thank you.
And from my perspective, I think it's important that these issues be lifted now. And in fact, I worry, and a lot of us probably do, that if this pandemic gets much worse, we might have an abbreviated session. And clearly, the more communication and analysis and shared information on these issues that can happen during session, the better off we will be in trying to do our oversight, and that the state will be in, and the department will know also where we are coming from. Are there any other questions or comments that are burning before we go to the next panel?
Madam Chair,
Yeah.
this is Bobby. We'll get answers to Senator Griffith's questions back to her in writing. I guess we could share them with the rest of the group if they so desire.
That would be helpful.
Yeah, and as far as the sort of like an interim report sometime during the legislative session, I think that's very doable.
I think we'd agree with that.
We'll plan on that.
Thank you.
Madam Chair.
Yes.
All right, this is Senator Hayes. Thank you so much. And I know you want to keep us moving along, but I am in possession of a letter that was sent over to Dennis Schrader and Dr. Jones on October the 6th to the department that had not received a response. I'd like, if possible, instead of taking this time, if we could have committee staff send the letter over to get responses on behalf of the multiple organizations that have inquired about the different concerns that they've been having as providers.
Please do.
Be acceptable. Excellent. Thank you so very much.
Okay, and thank you so much, Senator.
Madam Chair.
Right. With that in mind, we go on to hear now from the Behavioral Health Provider Panel. And we understand that change is always difficult and sometimes very frustrating. And clearly, when there was so much change happening with a new model and new entities trying to implement the model, and it are ending up in the middle of the pandemic, so that the greatest stress possible was put on the new model just at the time that it's still being worked out and refined, that it's tough on everybody. And we want our provider community to know that we really appreciate the very essential services that you give to our communities, to our constituents. And if things get worse, you might have to help some of us on an individual basis to get through what is here. So we're going to hear now from the provider panel. It might be quicker. We've got Laura Doyle, Kara Chu, Jeff Richardson, and C. Cott. If you would, in making your report, say a word about yourself or about the mission of the entity that you represent. Thank you.
Thank you, Chairwoman Kelly, Vice Chair Feldman, and Chairwoman Griffith. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. And Tammy, I think you should have my PowerPoint we sent the other day. While I'm waiting for that to come up, I will introduce Carrie Cho, who's the CEO of Cornerstone Montgomery, and Jeff Richardson, who's Vice President and Chief Operating.
Lori, we're
Yes.
having difficulty pulling yours up right now, but just give us a minute.
Sure, thank you.
Okay.
I also have with me Lauren Grimes, who's Assistant Director of CBH, just here to answer questions specific to billing or authorizations that you might have.
Okay.
Hey, are you familiar with Lori Doyle?
Of
Hi,
course.
Senator Hayes.
I'll tell you.
You want me to just start and see if the PowerPoint comes up? And I don't know, Lauren, if you can bring it up and try to share your screen. I'm not sure what to do at this point. I'm certainly no tech wizard.
Madam Chair, while we have a break, I have a comment.
Sure.
Thank you very much. Senator, I do want to stop for a second and congratulate Secretary Neal. For those of you who may not know, Secretary Neal started out as a lowly delegate, worked his way up to county executive, came back as a state senator, was on the second floor on Hogan's executive staff, and now serving as a secretary of one of the most important departments in the state of Maryland. It seems that when people ask him for help, he can never say no. And I have to share with you, Bobby, we're very, very honored to have you in this position. We'll miss you dearly. And I just want to let you know that an awful lot of people think very highly of you, including myself. Thank you, Madam Chair.
Okay,
Thank
we
you,
will
Ed.
second the motion, and it looks like Tammy has the slide up, right?
Thank you, Tammy. If you could go ahead and advance to the next slide. So CBH is comprised of 85 member organizations that provide services statewide. Our average member's been in operation for 44 years. So that means they predate even the first Administrative Services Organization, or ASO, that came into being in 1997. They're very experienced. They've been doing this for a long time. You've never heard a peep out of us, even though this has been our fourth ASO transition, because we've never had to come to you before. Most of these transitions have been fairly successful. There may have been a few bumps in the road, but nothing like we've seen with the Optum transition. It would be hard to overstate the level of disruption that we're experiencing right now, and that's everywhere from small providers up to and including hospital systems. Our providers are frustrated and they're exhausted at a time, as you pointed out, Madam Chair, that we're also trying to deal with the impact of COVID. Next slide, please, Tammy. So this is just to show you that the system is complex. Our member organizations offer multiple service lines, and these service lines that are included here are reimbursed in different ways. So some are reimbursed on a fee-for-service level. Some are reimbursed monthly based on encounter data at a case rate, and some are on a per diem basis. And so we figure that that contributes to Optum's difficulties. But again, the 3 ASOs prior to this were able to grapple with the complexity and get through it and provide an efficient service. Next slide, please. So here's the time frame that we're talking about. Optum was awarded the contract in July of 2019, and that was to give them time to ramp up for the go live date of January 1 of 2020. It became clearly evident when January 1 rolled around that the system was not prepared to provide authorizations or claims payment. And we went to the department and asked for estimated payments, these advanced payments based on historical billing. And to the department's credit, they granted that. I have to say that the estimated payments are viewed by providers as a necessary evil. Without them, we would have gone under. But we knew that the time would come to pay the piper. We knew that there would be a lot of work on the back end to rectify and reconcile these payments. So you can see the stops and starts, the number of times where Optum's billing system called Encato was supposed to go live, and it kept getting pushed back. And in fact, at one point in time, we came to you all and asked again for an extension of the estimated payments because the system was not ready. And you helped us. And again, thank you to the department for granting that. The system did finally go live in early August, and we saw immediately problems both with authorizations and claims payment. And so when you hear Optum's presentation, our experience has been very, very different. For instance, after this system went live, according to Optum's data, they're paying about the same as Beacon, the prior ASO, paid. But it's not an apples to apples comparison. What we saw was that we were not only getting paid for current claims, in other words, those things that happened after August 3rd, but we were getting paid again for things that happened during the period of estimated payments. So we were in essence getting paid twice, which inflated the number. And so we were concerned about that. We're still concerned about that. But you can see we're now 17 months into this contract and still have no confidence that Encato is going to be able to function adequately. Next slide, please. So one of our major concerns has been the lack of reports, the kind of reports that providers need to do revenue cycle management. These are not bells and whistles or add-ons. These are basic reports that any payer, whether they be in the public sector or the commercial sector, should be familiar with and able to provide. We've been asking for these reports for some time now and have been promised them, but we continue to wait. And without them, we simply can't post claims. We can't know what we were paid for and when, what was denied and why, whether we need to resubmit basic business functions. Next slide, please. So these are a couple of examples of the technology breakdown. And these are from individual providers, but they're representative of the provider experience as a whole. So on the left, you see a provider that submitted about 149,000 claims, but these claims are processed and reprocessed. So you submit a claim, it may get denied, then it's reprocessed and paid, but at the wrong rate. And it's reprocessed and denied again for a different reason. And this goes on and on. So that 149,000 becomes 202,000. And it's up to the provider to continue to track these things and try to make sense of it. It is extremely time consuming. On the other side is an example from a psych rehab provider. And psych rehab services are offered to the most at-risk people that we serve in the public behavioral health system. And it's based on encounter data, paid a monthly case rate based on number of encounters. This provider submitted about $7.3 million worth of claims, but was paid $5 million because about $2 million in those encounters were just missing. You submit the encounter and it goes dark. It goes into a black hole. It's not found. And so when the provider is paid, they're paid at a lower rate than they should have been. Next slide, please. So the technology has failed, and Encato's response and Optum's response to that has been to manually process claims, which is rather astounding in this day and age and the volume of claims that we're talking about in this system. It also introduces the human error into the equation. So now there are problems that are kind of all over the board. And it also adds to lag time between when claims are submitted and when they're actually paid. The analogy we have been using with Untitled is of purchasing a car that's a lemon. So you get the car home, and the first day the power windows don't work. And the second day, the radiator leaks. And the third day, the transmission slips. And the fourth day, the car doesn't start. And so it's not necessarily one problem all the time. It's problems that compound and change day in and day out. Next slide, please. So these are some of the basic functions that Optum continues to struggle with in Cato. Basic things, sending payments to the right provider. We still have providers that are getting payments for services that other providers perform. It's not only a problem in tracking, but it also raises some HIPAA issues. Insurance type. We know that in the public behavioral health system, people go on and off of Medicaid. They're sometimes uninsured, but still may be eligible for services. They may get Medicare, so they're dually eligible. And all that changes the authorizations, it changes the claims payment. This ASO has not been able to grapple with those changes in insurance, and that directly impacts things like authorizations. I have to take exception with the Optum presenter who suggested that authorizations are working well. They are not. And a lot of these things are leading exactly to those problems with authorizations. And then one of the big ones, of course, is processing clean claims within 14 days. Again, we're seeing lag times beyond 14 days, and I think part of it is the definition of processing. Prior ASOs, the 14-day limit was meant to be money in the provider's bank within 14 days, and they exceeded that expectation greatly. Now, the understanding is that processing just means that Optum has dealt with it, not that there's been a payment to the provider within 14 days. So there's a definite difference among us about what that actually means. Next slide, please. So now we're at that place where I referred to earlier where we have to pay the piper for the estimated payments. We knew we would always have to pay it back, and we knew it was going to be work, but we didn't expect it to be this problematic. We need three things in order to be able to do this. We need technology, we need tools, and we need time. Our providers have suggested that it's going to take a year to go through the hundreds of thousands of lines of data because of that processing and reprocessing issue to track all of these claims. I want to thank the department again for their decision to extend the amount of time that we'll have for reconciliation. But the problem is, unless we have those tools, those reports that I spoke about earlier, then all we're doing is allowing extra time to come up with the wrong answer. We need to have the way to verify Optum's math and to ensure that we're paying back the correct amount, or in some cases that department is paying the provider the correct amount. Next slide, please. So these are the things that we have suggested that we need for reconciliation. I won't go through all of these, but these have been communicated with the department and with Optum. I will say that I'm glad to hear that the call center will be changed and upgraded, but we're having problems with all of the provider relations. It seems that there aren't sufficient number of staff, that the people who provide that function are not necessarily trained. We get different answers from different people. There's lag times of a week or 2 weeks before we'll hear back. We don't have tracking numbers to be able to track a particular issue. So all of these are problems when you're trying to go through this amount of data. And next slide, please. So I'll just, close by reminding the committee that before this pandemic, we were experiencing an epidemic, and that epidemic was one of opioid deaths. It was one of rising suicides. And we need to be able to focus again on our clinical mission to deal with what looks like an exacerbation of these problems. Some of you may have seen a recent Lancet article that found, surprisingly to them, that for people who were diagnosed with COVID, 1 in 5 will develop a mental health diagnosis, most likely depression or anxiety. And for people who already have a mental health diagnosis, they are 65% more likely to contract COVID. So we're getting hit from both ends. We need to be able to pay attention to this. We're trying to shield people in need from harm. Providers continue to provide services, even though we may not have an authorization, even though we may not have gotten paid. But we can only do that for so long. And I think that is the concern, not only the provider community, but you should have seen a letter from the Behavioral Health Coalition that had 80 organizational signatories on it expressing concern about Optum and Encato and this transition. So I will just again close by saying that first off, we thank the department. We thank Optum for the time they have spent with us. We have been meeting incessantly dating back to 2019. I can remember being on the phone with COO Schrader on Christmas Eve, New Year's Eve, daily, trying to work this out. Our belief is if they could have fixed Encato, they would have fixed Encato. But I think this dog simply doesn't hunt. And the thought of 4 more years of this is just unconscionable. So I thank you all for your time.
Thank you. Carrie,
Yes.
I just ask, any particular question there, or could you hold them till we hear from everybody on this panel? Okay, Carrie, why don't you proceed?
Okay, thank you. Good afternoon, Chairwoman Kelly, Vice Chair Feldman, Chairwoman Griffith, and members of the Finance Committee and Health and Human Services Subcommittee. I am Carrie Guthrie-Cho, the CEO of Cornerstone Montgomery, one of the behavioral health providers that has been struggling to deal with the Optum transition the last 10 months. The impact of this ongoing fiasco has been administrative and clinical. It is negatively affecting both staff and clients. And while we appreciate that the Department of Health has been communicating and working with us to fix the problems, we truly have not seen any substantive improvements. Cornerstone Montgomery has gone through 4 ASO transitions in the last 23 years, and we have never experienced anything like this. As we work with the Department of Health and Optum, timelines are constantly changing without any formal announcements. We only know what is going on because of the weekly CBH Trade Association meetings. For example, you've heard mention of all these reports that we're still looking for about payments and denials that were supposed to come out on November 6th. Now they're saying the reports will come by November 30th. We've actually been getting reports like this randomly for months, but in 1 week, a claim will be retracted twice, and the next week, it'll be paid 3 times. This is a nightmare for our billing staff. They are literally reconciling payments and denials multiple times for individual services. Optum's system continues to be unable to effectively authorize services, reliably pay claims, or provide the reports needed for providers to post and track the status of claims. Cornerstone Montgomery had authorizations for services in our employment program that should have carried through the transition, but did not pull through. That resulted in hundreds of hours of administrative work from our staff who should have been providing services to clients, but instead they had to resubmit over 500 authorizations. In addition to dysfunctional authorization systems, the claims payments are also problematic. As a result, providers, as you know, we got the estimated payments, which ended in August. They were based upon last year's billing, and now we're working on reconciling those. When live claim processing started in June, as you heard from Lori, we started getting payments for services that had happened during the estimated payment months. So we were getting paid twice for old services while live claims were underpaid. In fact, we've been underpaid since the live claims started, almost $1 million based on our estimates. The fact that these reports continue to be wrong only adds to the confusion of reconciling the estimated payments. And we also agree that this is going to take months, if not a year, to resolve this reconciliation. Hours of administrative work that should be done, spent doing other things. And truly, we don't even know if they've gotten all of our claims because the reports are so inaccurate. So we're not even sure how reconciliation is going to be able to happen. At this point, we've experienced about 6 payment cycles from Optum since estimated payments ended, and we're still only receiving a fraction of the claims we've submitted. Behavioral health providers have been chronically underfunded, so we cannot withstand even short periods of time without payment. My organization employs over 300 people, and we are very concerned about our ability to make payroll if Optum's functionality is not quickly fixed. We continue to see denials of services for reasons that don't make any sense. Many of our clients have both private insurance as well as Medicaid. Private insurance has never covered our services, but we're being told we have to bill it and be denied before we can bill Medicaid. That doesn't make any sense. We've never had to do that before. So at this point, we're continuing to get denials based on clients having other insurance, and until this is fixed, we are not getting paid. Recently, a client had his PRP authorization denied due to having a concurrent authorization open at another agency. The client called Optum and had difficulties with the representative who spoke to him because they spoke over him and they used rapid fire questions. The client became visibly agitated, requiring staff support to complete the call. At the end, the representative said the issue was fixed, confirmed that the client had selected Cornerstone Montgomery as his PRP provider. When we reprocessed the auth request, it was again denied for the same reason. You can imagine how the client responded when he was told he was going to have to contact Optum again. There are many other examples that I could share, and while there have been efforts to make changes, we have not seen the improvements that are needed. Significant problems with Optum continue to hamstring our operations, tie up significant amounts of staff time, and threaten our financial well-being. I am worried not only about our organization, but about the clients that will suffer if providers are no longer able to sustain and pay their employees. We provide treatment and services to 2,500 individuals in Montgomery County. And simply put, if we have no employees, that means that all of those people suffering from mental health and substance use disorders complicated by the pandemic will go untreated. If Optum or Encato cannot perform the functions of the contract, then I believe that one or both of them should be replaced. And again, I thank you all for your time and your consideration. Thank you.
Thank you. Jeff Richardson?
Jeff, you're muted.
Can you unmute yourself, Jeff?
I can unmute myself. Thank you.
Okay.
What I said was really important, so, oh well. I want to thank everyone for their time today. And, you know, again, I want to echo what's already been said. We appreciate all the work that the department has put in to working with us and Optum. Everyone has worked day and night to try and fix the system. But I just want to comment on what Lori said, which is this dog does not hunt, it doesn't even walk. This is not working. The system is not working at all. And to give you a sense of the scope, I have been in behavioral health for 35 years. And I have lived through all of those transitions from one ASO to another. And this is extraordinary. And we're talking about this in November when we've had transitions be difficult for a few months and then we've moved on. What Carrie just mentioned, it is having an effect at a time that we don't need distractions. The demand for our work is more significant than it's ever been. That we need to be fully focused on those efforts. And so to give you a sense of scope, Shepherd Pratt bills about $160 million under Medicaid under the ASO. And in that is almost 1.3 million encounters. And I don't bring that up just to show you how many services we do, but when it doesn't work, how complex and disastrous it can be. You know, the services that we bill under are inpatient services, hospital-based outpatient programs through 11 community mental health center sites, inpatient through over 400 beds, crisis beds, 77 beds, residential rehabilitation beds, over 769, and psych rehab programs at 11 sites throughout the state of Maryland. And, you know, I think the comment earlier too about the call centers not getting the same level of complaints, my staff are telling me that they've lost confidence. And so calling again and again without getting the response is very frustrating. But I can tell you, we continue to be committed to fixing the system. We know everyone on this call today is dedicated to taking care of Maryland citizens, but it is getting more and more difficult. And let me give you a few examples of some of the areas that we're struggling with. Under authorizations, from the very start of this long, tumultuous year, we've had and continue to have issues with routine authorizations, including the following: no explanation for authorization denials, inconsistency with authorizations, Administrative days that have increased by Optum without warning, reducing the amount of collectible per day by 60% for the same level of care. A system was set up by provider type, which creates challenging moving authorizations for a single patient that moves between provider types. So just Carrie's comment, just multiply that if someone's in more than one provider and more than one service at any given time. It is not working well. Claims processing issues. There's been no planned outline for the reconciliation process for estimated payment period claims, which represent the bulk of claims requiring additional workforce. Overpayments. Inpatient and residential claims not paying by the correct discharge date. Services paid at incorrect rate. Insurance issues creating a large percentage of denials. Patients that were not billed are being paid. We're also, as Lori mentioned earlier, we are receiving patient data from other providers, which is significant HIPAA and privacy issues. Around authorization, around auditing issues, this is creating a nightmare for us knowing really how much we actually have been paid. And in fact, our records versus, what we're getting, we are off by millions of dollars. The other concerns that have been already identified around, around the call center are significant. The lack of valid reports with the reprocessing of claims multiple times. And in fact, we just received a reconciliation sheet with 540,000 lines in a spreadsheet to try and reconcile. Just imagine that. And again, the time, labor, and focus and effort around doing this is distracting us from our normal business, which is critical. We talked already on this call about the call center. And again, we appreciate everyone's dedication to improving that, but they've not been adequately trained in the Maryland Medicaid system. And the results of inconsistent messaging from call center staff, while these issues escalated, they remain unresolved. And we have a lot of unresolved issues that we're still working through. The problems with Optum and Cato system coupled with sustained losses leave Shepherd Pratt exposed to cash on hand issues, loss of margin, and continued audit issues and resource constraints. So the extent of denial and authorization issues are currently unknown from a cash and revenue impact. So we really just don't know. Administrative days amount to $1,000 per day, per patient day, and unknown if this will continue at current frequency. Overpayments resulting in liability to Optum the number is currently absolutely uncertainly not clear. Auditors are unable to test and confirm balances and rely on Optum reports. And workforce issues include additional time to process authorizations, claims management time, and effort have been dramatically increased. The expense and impact beyond time and workforce stress is not known. And we literally are burning out our staff addressing these issues. And so our requests are a continued effort that you guys have already talked about, which is additional transparency on these Optum issues. We thank the state legislature and also the Department of Health for their continued work to work through this and expose any of the issues at hand. Maintain the estimated payment system while the Cato system becomes operational. The waive provider liability for the estimated payment period. And training resources for call center employees to adequately support provider issues. And then the last really is just an obvious but an important one, which is whatever system gets employed, that it's organized, tested, and an articulated approach to managing this system. And again, the fact that a lot of these things were not tested prior to their implementation is just astonishing and as something that we've been paying for over and over again. I'll stop there. And again, thank everyone for their time and interest in this issue. But we as a provider community are fully dedicated to serving people through this. But it is a very difficult time. Thank you.
Thank you. And finally, Ann Seacott.
Good afternoon, Madam Chair, Chairman Gazzoni, and all the committee members. Thank you for the time. I am representing both the Maryland Association for the Treatment of Opioid Dependence and the Maryland Addiction Directors Council. Howard Ashkin, the immediate past president of MATOD, is available on the Zoom to answer any questions members have that are specific to substance use disorder programs. These two organizations are the statewide associations representing the continuum of treatment programs for people with substance use disorders, and are two of over 80 organizations with the Maryland Behavioral Health Coalition that had signed onto a letter sent to state officials last month calling for the end of the contract of Optum's IT vendor in Cato. I believe you all have received that letter. Every type of provider has had and continues to have problems with the new ASO, and we support the detailed information provided previously by Ms. Doyle with CBH and the providers. The providers with the organizations I represent, like their partners, would rather this new ASO and the IT vendor actually have a well-functioning system, especially during such a difficult year. No one wanted to have to turn to estimated payments, but the state was forced to take that step when the system failed to function when it went live. We appreciate the countless hours representatives from the department, from Optum, and from our community partners have spent troubleshooting and trying to make the system work since January 1st. But we have no faith that it is possible to fix this inflexible system. And because of these deficiencies, we don't have faith in the accuracy of the department's estimates regarding overpayments to providers. You've heard extensively, I will not repeat the problems with authorizations, with claims payments, and we're appreciative that the concerns about the reconciliation process have been heard and that the health department is proposing at least a more realistic timeline for the whole reconciliation process. I cannot stress enough, though, every single treatment program has had to significantly change how it operates because of the pandemic, and at the same time has had to divert resources to these administrative burdens. You've heard how inaccurate and incomplete information is given to providers. That's going to really exacerbate the reconciliation process. You've heard of the issues with communications with Optum. These are not problems inherited from Beacon. Every treatment program has spent untold administrative hours trying to work within this system. Every treatment program will need to spend a significant amount more in the reconciliation process. Some programs have hired additional staff already to deal with this. This is not an efficient way to run any business, let alone a healthcare program in the midst of a public health crisis. It's also important to note that while we've been focused at this hearing on the impact of Optum's failure on treatment programs, Optum also administers non-clinical funds, including payments to recovery residences. They too have suffered the 1-2 punch of a dysfunctional ASO and a pandemic. All of this is happening at a time when we are seeing an increase in opioid overdose deaths. Recent data from the state also shows the growing racial disparate impact of overdose deaths in Maryland. We should be focusing our attention on addressing this crisis, along with the significant increases in depression and suicide, rather than spending so much time and money on Optum's IT failure. We genuinely thank you for hearing our concerns.
I want to thank everybody on both panels, and obviously everybody has goodwill. I think people on both panels have tried to indicate that they know there are problems and that they must be solved. Let me ask one thing of anybody on either of these first two panels. Something that occurred as I just sat here listening. In the future, and maybe even in trying to fix what is ailing us now, would it be possible, and is there a legally sufficient way of having persons from a provider community who do the administrative and budgetary and reconciliation work to serve as blind entities when you're working on your specifications and you're planning to put a bid out for a continuation or for a new service, if there were a way to shield who the submissions are coming from, but even maybe before then, when you're trying to decide what to ask for in your request for a bid, to have people who do the work sit in some kind of a blind or semi-blind status, able to give input that no person whose job is to be an administrator in the health department can know as well, because you aren't maybe the specialist in anything. You have to have a broad knowledge of so many things cutting across so many different types and lines of service. That's kind of my question. And I'd be interested, if we don't take a lot of time with it, but it's something that I'm wondering about. Is there a legally sufficient way in which, when you start out from the beginning to decide a contract with a major services expiring and you need to put out a request for bids, is there a way that people who do the work, some that you know are doing it well under your pre-existing setup, could help you in a blind way to be sure you're looking at things you can't possibly have thought about in advance? And I think I see the Secretary's hand up.
Madam Chair, I think it's an intriguing idea. Not being a procurement specialist or a lawyer, I'd have to carefully consider that, but I think there could be a way to do that. I'll tell you something else that I learned is that you need more time when you're unpacking a 10-year incumbent. You know, there's a lot of stuff in the closet that needs to be cleaned out. And if I ever get in a position where I ever do this again, I will never, ever, ever execute a technology platform on the 1st of January, because the couple months leading up to you have people taking holidays, the productivity goes down, the whole pace, the whole tempo goes down. And so I think we need to watch our effective dates, because that contributed in no small part to our difficulties.
Chairman Kelly, if I may add to what the Secretary just said, I think there's a procurement issue overall, not just providers being allowed to kind of look at the contract specifications and make suggestions because the fear of challenges down the road if we are involved. But I think looking at this contract over time, and this is the 4th ASO, each time the lowest bid vendor gets chosen. And what we've seen over time is a steady erosion of the quality of these vendors. And we have spoken with the folks at the Board of Public Works to say, this is a different kind of procurement than if you're purchasing, widgets or paper. These are human services, and sometimes the low bid is not the value bid. Thank you.
Okay. Are there any other burning questions before we move to our next subject?
Senator Klausmeier has a question.
Yes, okay, Senator. Did you unmute yourself?
I have a question and just a comment. Before I came on today and over the past umpteen months, we've talked about these problems, and I've heard them all. I've heard recovery homes are closing down, and Optum isn't doing this and Optum isn't doing that. And I'm glad to hear about the reconciliation when that occurs, but I just see such a parallel with the unemployment system. The system will always break, and as Secretary Neal said, that maybe the dating is wrong when it happens, but something has to be done. We've been talking about the providers, and Jeff, he did mention, and so did Carrie, mention this is affecting our patients. Laura, you did too, and we've got to fix this. And as I said, I am just so frustrated between the two departments, and I know everybody's trying to do their fair share, and do what they can do. But I'm just speaking for all those that have contacted me and had many questions, and I know that I'm not going to ask them all, and I'm sure there's a lot of other people that have lots of questions, and I hope this whole conversation will continue. But along with Chair Kelly, I know the unemployment did hire, they put an RFP out to hire people that knew some of the unemployment works, and they hired 300 people they have specifically deeds to do. So I'm hoping maybe the department will look at that. And again, let's all work together. And this isn't the end. We have patients out there, we have constituents, and we have providers that need help dealing with this. So thank you.
Thank you. Let me ask you, Secretary Neal, what kind of legal constraints are we under if we were to decide that it isn't anybody's fault at this point in time, but that a real change contractually needs to occur? Are there ways of backing out of where we are and rethinking? I mean, when you consider this state is going to be suffering for decades from the pandemic that we're going through. And people that normally might have made it through life thinking that they were emotionally pretty healthy, in many cases are now in a state of depression, and some of it's going to become clinical depression. Just living with so much death around us and with so much lack of control of our daily lives. I'm just wondering if the department does have, under circumstances such as this, some kind of a legally sufficient way to consider going back out to bid or rethinking what needs to be a part of a bid that would be more workable.
I'll answer that two ways, Madam Chairman. First of all, we've reserved all of our legal rights under the contract. I think we've withheld some money, and I just didn't think that it would be productive to have a two-pronged strategy where we're trying to fix this thing and we're beating each other over the head with clubs. And my advice, and this is easy for me to say because I'm on my way out the door, but I would slog through the next 6 months and see if we can't get there before I would throw my hands up and start over, because despite our best efforts, it's going to take a good 1.5 to 2 years to do that procurement anyway. So I would spend my time on trying to get this right, even if it means new software and some other modifications that takes it out. But I don't think I'd throw it out at this point.
Okay, but it is helpful to know that you have a legal option should they be needed in the long run.
We reserve those, yes.
Thank you. Is there, Madam Chair of the subcommittee, do you have any comment before we leave this issue and move to the other?
Madam Chair, I think my questions have been asked, but I do see Senator Hayes had a question.
Okay, Senator Hayes.
No, Madam Chair, and thank you, Madam President Pro Tem. But to your point, Madam Chair, I think one of the options, and the Secretary just spoke to it, in some states, instead of having the vendor operate both the technology as well as the delivery of services, the state would have ownership of the technology and they would contract with a vendor to manage it. There's nothing in state procurement law that would preclude Maryland for exploring the same option. I would just hope in all of the different scenarios that the department explore that be one of them.
Okay, another idea.
And Madam Chair, I don't know if you noticed, but I certainly didn't want to move on without acknowledging the distinguished chair of the Budget and Tax Committee, Chair Guy Gazzone, and I don't know if you wanted to add anything.
I didn't know he had arrived. Thank you, Mr. Chair. We do want to hear from you.
Thank you, Chair Kelly. really can leave this in your capable hands and the capable hands of Senator Griffith from our subcommittee. I don't know, just listening to the whole thing, there just seems to be a complete disjoint between the company's side and the provider side. And I don't know if we have the time to actually hear sort of the complete back and forth on that. And I'm actually tempted to have a discussion afterwards with hopefully a representative from both sides maybe, and sort of have a back and forth. This may be a little too unwieldy at this point. But I do thank you very much. To me, it's just, they're just things going in both directions, and it doesn't click. I don't understand why both sides seem so far apart from their perception of this.
Okay. Thank you, Mr. Chairman.
Thank you.
We know that everybody here is a person of goodwill, but goodwill alone do it. And that's why I've asked some questions that might seem pretty abrasive, but we need to know what tools we have in the toolbox should we need them. Okay, well, let's move on to this other question, telehealth. Obviously, we moved to new modalities during the pandemic for delivering medical services, and we did so in a rush because nobody could have known this was coming. And we're where we are. We don't have 5G in many parts of the state to even deliver this option to everybody in Maryland, which is one concern. Even where there is infrastructure geographically in a community, not every Maryland resident who might need the services, and everybody needs health care, can personally access what is necessary. I have been looking at the National Council of State Legislatures website and seeing what some other states are doing in this regard. And one thing that is a question often raised is whether privacy and whether scams are two issues that whatever we do moving in this direction and in the direction that I know the state is considering, would have to be additional considerations. Some symptoms can perhaps be very well assessed through telehealth modalities. There are many others that absolutely won't work. And could we lose time in some instances having a partial review of our health condition through a telehealth modality, only to be told, well, to find out the rest of the story so we know what to prescribe or what to do next, we need to go back to a more traditional modality. We obviously want to take advantage of new modalities that work, and we have gone there. We've been in a telehealth modality in a way we ordinarily might not have. And for some people, it's working well. I'm going to shut up and call on first the representatives of the Department of Health and from the Maryland Insurance Administration, and then we'll go to the provider community without a lot of intervening talk, and then finally to the Healthcare Commission. So if our first panel, Webster Yee, Alicia Brown, Kathleen Barain, Commissioner of the Insurance Commission, and David Cooney could speak with us, we'll move there next.
Good afternoon, Madam Chair. Could I please ask committee staff to bring up the Health Department's PowerPoint?
Sure. And thanks so much for being here to help us today.
Absolutely, our pleasure. Hopefully there isn't background noise from the room next door, since I just hopped over a room. With me is my colleague, Alyssa Brown, Deputy Director of Innovation, Research and Development. group in our Medicaid program. If I could get the next slide, please. We're having technical difficulties. I'll just get started. On the telehealth side, the health department has been working very closely over the past couple of months and really over the past couple of years with the Maryland Insurance Administration, the Maryland Healthcare Commission, and the 20 health occupation boards and the 4 commissions to ensure that telehealth flexibilities for Marylanders are both available and accessible during a COVID-19 declaration of emergency and catastrophic health emergency. For telehealth, and you're going to hear a lot of information from the MIA and the Healthcare Commission, there's really 3, almost 4 basic areas that you need to kind of think through. Generally speaking, the first question is, what does federal law say? And luckily or not, during the state of emergency, the federal government has relaxed flexibilities. And so they've specifically relaxed the audio-only prohibition, basically. And then they've also lessened HIPAA requirements on technology. The second part is, what is the state doing? The General Assembly in the 2020 session passed the telehealth bill, which amended things a little bit from the previous statutory and regulatory regime. And we are working through with the health occupation boards the development and promulgation of regulations. And then third, and the Insurance Administration is going to talk about this, it's how do you get the private carriers to also adopt various telehealth measures. And then lastly, of course, during the COVID emergency, what are the orders, the various departmental and governor's orders that we're talking through, and how do they impact things? So with that, if I could get the next slide, please. So specifically, House Bill 448, Senate Bill 402, the 2020 session provides a new statutory basis for telehealth. So in 2019, 2018, all of the health occupation boards, pursuant to a slightly older telehealth bill by, I believe, Delegate Resnick, they put through a new regulatory, we promulgated a lot of new regulations. And the basic administrative thrust of those regulations was to ensure that if, say, a nurse practitioner or a nurse started off a telehealth session and then handed over to iPad or iPhone or computer to a doctor or any other health care provider, that you would have a smooth transition of service. With House Bill 448 and Senate Bill 402, they allowed for a new set of things, including asynchronous telehealth services. But crucially, the bill does not permit telehealth health services through audio-only calls or emails or faxes. So there was an executive order that was issued very early on in the COVID-19 state of emergency, where the governor suspended the operation or the prohibition of that audio-only bit and allows healthcare services to be provided through real-time audio-only calls. If I could get the next slide, please. In addition, the Department of Health's Medicaid program has implemented, we've asked the federal government and we've received permission to implement a large number of temporary flexibilities. And all of these flexibilities are tied both to the duration of the federal public health emergency, which currently has been extended to January 20th, 2021, and then also through the state of emergency. So the combination of both the federal declaration and the state declaration have provided the framework for these flexibilities. And the two principal ones, again, are this allows the usage of non-HIPAA compliant technology. So in other words, you can do a Skype call or a FaceTime call or any of the more consumer level technologies versus using a telehealth specific system through an electronic medical records, et cetera system. And it also allows audio only services. And the two of them combined have really, I think, changed how all of us in the healthcare industry have looked at telehealth. And with that, I'll turn over the baton to my colleague Alyssa Brown, who can talk more specifically about what Medicaid has done. Next slide, please.
So thanks so much, Webster, and thank you, Madam Chair and members of the committee for the opportunity to present on behalf of the Medicaid program. In terms of some of the flexibilities that Medicaid focused on in implementing during the public health emergency, we've really been focused on the safety of not only our providers, but also our participants while ensuring their ability to access care. So we've implemented a number of different flexibilities through telehealth with that intent in mind. That includes permitting services in a participant's home or another secure location. I do want to emphasize that point. There's often some confusion, but we do cover other secure locations as well to serve as a telehealth originating site for the purposes of covering the delivery of Medicaid covered services. As Webster highlighted, we're also permitting reimbursement for services delivered by audio only, which traditionally, as you know, has not been considered a telehealth modality, as well as permitting use of certain telehealth technologies that are not compliant with HIPAA. And I think Webster did a nice job of highlighting some of those, FaceTime, those types of things that wouldn't traditionally be used for telehealth. And so really we've implemented a constellation of different federal waivers to cover these different flexibilities in tandem with a number of different state flexibilities. Next, and one of the things that we are doing is evaluating what services may be appropriate to deliver by telehealth on an ongoing basis following the end of the COVID-19 pandemic. We recognize the value in a lot of the services that have been covered during this time, and our clinicians are reviewing those different services very closely to determine which services may make sense to implement on a permanent basis. Next slide, please. As I mentioned, there is a whole host of different types of federal waivers that the state has procured at this time to be able to have the flexibilities that we have, not only with respect to delivery of services via telehealth, but also a number of other operational aspects of our program. I won't go through each one of these individually, but of course, it's never as simple with CMS as executing just one waiver. We've had to seek authority through a number of different types of waivers. So that includes our 1135 waiver. And probably most important for telehealth concerns, I'll highlight that one of the waivers we have through the 1135 authority is of the 4 walls requirement. That's a requirement for clinics in the community, including school-based health clinics, to have either the clinician or the participant receiving services on site. We've gotten a waiver of that because we're aware many clinicians may not be operating within the 4 walls of the clinic during this time. We have a couple of different disaster state plan amendments that date back to the start of the public health emergency. And again, these authorize us to do a number of different things, but do have include our authority for the audio only and some of our expansions for our remote patient monitoring services. We also have a couple of 1915K amendments, and these govern services through our home and community-based services waivers. We have one for DDA and a different one for the remainder of our waivers that the Medicaid program operates. And then we also have something called a concurrence approval by CMS. And this is really actually just seeking authority from the department and emailing CMS and getting granted that authority just by email. And this is probably one of the more important authorities that we have, which permits the state certain flexibilities in terms of application processing and allowing us to delay our redeterminations during the course of the public health emergency. And we're working with CMS on unwinding that eventually as well. There's a couple of other flexibilities included in here that I do want to highlight as well. We have suspended premiums for both our MCHIP program and our Employed Individuals with Disability program. So we are not charging anyone for those premiums during the course of the public health emergency. And there's a number of other flexibilities outlined here. We actually have all of these documents posted on the department's website that you can peruse at your leisure. They're all very comprehensive. So I won't have time to go through those full flexibilities today. Next slide, please. One of the major impacts we've also seen during COVID-19 is a substantial growth in terms of our overall enrollment due to the maintenance of effort requirements put upon us by CMS and the Families First Coronavirus Response Act. So under that legislation, we are required to maintain the enrollment of individuals who were enrolled at any point on or after March 18th in Medicaid until the end of the national public health emergency. And by doing so, we do qualify for an enhanced FMAP of 6.2%, which does enable us to leverage some additional federal funding to offset the cost of this increased enrollment. So just by way of example, our standard federal match rate for most of our population is 50%. We can leverage an additional 6.2% on top of that to help offset costs. There's one thing I do want to note here that's often a source of confusion, which is the difference between the end of the maintenance of effort requirements and then that enhanced federal match rate. So the maintenance of effort requirements sunset at the end of the month in which the public health emergency expires. In this case, with it set to expire on January 20th, we'd expect that maintenance of effort requirement to end at the end of January, whereas the enhanced FMAP would be available to the state through the end of March. I will note that a new interim final rule was published on November 2nd, introducing some flexibilities for states with respect to the maintenance of effort requirements. The department is in process of reviewing that, but essentially it means that we have some flexibility to move individuals between different types of coverage, so long as that coverage change continues to meet minimum essential coverage requirements under the ACA. A good example of a change that we would now be permitted to do is if a child ages out of their coverage under children's Medicaid, they could be moved into an adult group so long as they can access the same level and type of benefits as they did before. Next slide, please. So because of the maintenance of effort requirements and the suspension of redeterminations, we have seen substantial growth in terms of overall Medicaid enrollment over the last several months. Prior to the onset of the pandemic in late 2019, we were actually seeing some declines in terms of our overall enrollment, largely attributable to the good economy. But we've seen a steady increase since the start of the pandemic in March. Average enrollment for Medicaid is typically around 1.4 million enrollees. This enrollment number here is from November 6th. We had over 1.5 million individuals enrolled in Medicaid. And we continue to see steady growth over time. We're adding approximately 1,000 enrollees every couple of days over the course of the pandemic, and that's maintained a pretty consistent trend over time. Just yesterday, our enrollment had increased by about 7,000 people over the number you see on this slide. Next slide, please. And then I also just wanted to highlight where a large part of the growth is coming from. So we're seeing relatively level enrollment amongst our older adults population, but those who qualify on the basis of income, particularly our adults qualifying on the basis of modified adjusted gross income, are driving a substantial part of that increase from the 1.4 million to the 1.5 million. So you can really see that growth trend here on this slide. Next slide, please. And then this is the last slide for the Medicaid program, but I did want to offer just a couple of resources for your consideration moving forward. We've made a comprehensive effort to make both the public, our providers, and consumers aware of some of the flexibilities that the department has put in place over the course of the pandemic. That first link is for our provider information page and includes a substantial amount of guidance. As Webster said, we have both state and federal authorities in place for these flexibilities. So it includes a list of and links to all of the secretary orders, as well as the related guidance that the department has issued. And at the bottom there, you can see on our main page, we also have all of the federal waivers that I mentioned posted and available for public review. Thank you.
Thank you. Commissioner Brain?
Hi, we have the MIA slide deck, I believe, if that you would be.
Okay.
Appreciate that very much. Thank you.
And welcome.
Thank you. Appreciate that. And Mr. Cooney is with me also. So good afternoon, Chair Kelly, Co-Chair Feldman, Madam President Pro Tem Griffith, Chair Guzzoni, members of the committee. Thank you for the opportunity to present to you today on the important topic of, I think that's the, yeah, we had a separate one.
We're having technical difficulties again.
No
Just
worries.
give us 1 minute, please.
That just shows we're human.
That's right. That's right. It's our new normal.
Well, while we're waiting, you have anything else to help make us smarter?
Well, let me go through my portion because I think we're good with that until we get to Mr. Cooney's portion, and he's really then going to go over slides that have data.
Okay.
My introductory part I can do without the slides. Oh, but there we are.
Okay.
Perfect timing. Thank you. And thank you for the opportunity to present to you today. I'm Kathleen Borain. I serve as the Maryland Insurance Commissioner, and presenting with me today is David Cooney, our Associate Commissioner for Life and Health. Our presentation today is going to really focus on what is the current statutory law in Maryland with respect to health insurance coverage for telehealth services. What have we seen in terms of the exponential increase in telehealth services as a result of the pandemic? What kind of accommodations have carriers been willing to provide voluntarily with respect to telehealth, and how the law would need to change to make some or all of those voluntary accommodations legal requirements in the future. So if we could have the next slide, please. So just briefly, carriers are required to cover all otherwise covered health services that are appropriately delivered through telehealth. And telehealth, you'll see in subsection A, is pretty broadly defined as really any interactive audiovisual telecommunication electronic technology to deliver healthcare services. But importantly, it excludes audio-only telephone conversations, emails, and facsimile transmissions, similar to what Webster was discussing at the federal level in Medicaid as well. Carriers are not required to reimburse a healthcare provider who is not a covered provider under the insurance contract. And the statute doesn't address any form of parity in payment, not between audio versus visual, which of course it wouldn't because it doesn't cover audio only, and not with respect to a video consultation versus a live consultation. Carriers are permitted to apply cost sharing for services that are delivered through telehealth, and carriers are permitted to perform utilization review to determine that the provision of these services through telehealth was appropriate, subject, of course, to review by the Maryland Insurance Administration. So the pandemic has resulted in an exponential growth in the use of telehealth, and David will go over that. We've stayed in very close contact with the industry throughout the pandemic. We have required carriers to identify the contract accommodations that they've made so that we've been able to track that, including the accommodations they've made with respect to telehealth. And we've more recently surveyed, and we'll share with you today, information from insurers regarding the volume of telehealth claims that they've seen. And with that, I will turn this over to discuss the expansion of telehealth utilization, the voluntary accommodations, what the MIA's actions have been, and then I'll come back just briefly to talk about some of our lessons learned and some considerations for you as legislators.
Okay, thank you.
Thank you, Commissioner. So this is David Cooney, and I would like to start with this visual representation of the tremendous growth in telehealth utilization that we saw by covered members in the commercial market once the pandemic hit. So the next two slides include bar graphs illustrating this data. This first slide here includes all 5 carriers in the same graph. And it's more helpful to show the overall volume of telehealth utilization, while once we move to the next slide, it splits out individually all the carriers, and it's kind of more helpful to see the trend per carrier. But as we start here with this graph, the one thing I want to note to begin with is carrier 4, who is the purple bar you'd see on that graph, Some of their data does include some regional data from DC and Virginia because they were unable to parse that out and only report the Maryland at this time. So their numbers might be slightly inflated, but they indicated that the trend would be the same regardless. But for all 5 carriers here, this is insured business only. It does not include any of their self-funded plans that they administer. And I think with that data point, knowing that, it just makes these numbers all the more astounding. You'll also note the red bar there, carrier 2. They were the one carrier that was somewhat of an anomaly in that even prior to the pandemic, they already had a very high level of telehealth utilization. So they skew the trend a little bit, but we can talk about that and pull that out in a minute. So the first column here on the chart represents the pre-COVID numbers. And with the exception of carrier 2, you can see it's very minuscule utilization. It can kind of range from about 100 to 781, depending on the carrier. Carrier 2, however, had over 22,000 encounters an average pre-COVID. So altogether, there was about 24,000 for all the carriers. In March, when the pandemic first started hitting here in Maryland, it immediately jumped up to where we had over 94,000 telehealth encounters for all 5 carriers in Maryland. And then as we really started approaching the peak in April, that went up to over 225,000 encounters. The highest point we reached was in May, and that was over 250,000 encounters. And then for the next several months, it decreased slightly. But the last month where we have data from all 5 carriers is September. And even in September, we were still over 177,000 telehealth encounters. And for October, the carriers who did report data, it was pretty consistent levels there still. So one last thing I'd like to mention here, if you just kind of want to look at the magnitude increases, comparing the pre-COVID numbers to the peak and then to where we are now. If you look at May, where we reached the highest numbers, what we had there was a 10-time increase over the pre-COVID numbers when you include all 5 carriers. And if you factor out carrier 2, who had the high pre-COVID levels already, it's actually an 80-time increase. And then when we look at where we are now in September, for all 5 carriers, the telehealth encounters are 7 times higher now than they were before the pandemic. And when you factor out carrier 2, it's 52 times higher. So if we can move on now to the next slide. And as I said here, this is the same information. It's just pulled out so you can see the trend per carrier a little bit better. And just to summarize this briefly, carrier 1, when we compare where we are now, the most recent data we have is October, and we compare that to the pre-COVID numbers, it's an increase of 32 times. Carrier 2, who was the one anomaly, even there, it's an increase of 3 times. And one other point I'd like to note about carrier 2 is they indicated that between March and May, a full 85% of all their encounters were virtual. And then in the couple of months following that, they remained steady at about 50% virtual versus 50% in person. And of the virtual visits, half of those were audio only. Moving on to carrier 3, the increase we saw there up to September, which is the most recent month we had, it was an increase of 82 times. Carrier 4 was an increase of 45 times. And finally, carrier 5 was an increase of 14 times. So as we consider this data, we definitely recognize we're still in the midst of the pandemic, and we're not really sure what the new normal is or where these numbers will balance out. But from all our discussions with the carriers, they all acknowledge that there's really going to be no going back to the pre-COVID levels, and this increased utilization is certainly here to stay. There are obviously several factors that contribute to this growth in telehealth, including on the one hand, fear and caution over face-to-face encounters by providers and patients. Also just general concerns with mitigating the spread of COVID-19. But it is important to note that some of those changes at the federal level were really critical in allowing the expansion to occur. And the Department of Health already touched on those, the federal OCR enforcement discretion and some of the CMS waivers and guidance. And although a lot of that really applied to Medicare and Medicaid specifically, it really acted as drivers for broader changes across all markets. And if those changes are not made permanent, it will be difficult to sustain some of this telehealth expansion. So these next 2 slides describe the carrier's response related to telehealth during the pandemic, as well as the MIA's actions. I'm going to go through them together because they really go hand in hand. And I'm actually going to start with some of the information from the next slide, but you can leave it on this slide for now, that's fine. So At the beginning of the pandemic, what we did as the MIA in relation to telehealth, we started off by examining the requirements under the existing law, and we reevaluated them in the context of the pandemic, specifically thinking along the lines of what types of care are medically appropriate to be delivered via telehealth in a pandemic versus a regular normal environment. We considered what options we had with our emergency powers, but we didn't really see where we necessarily had authority to require significant changes. So in our first COVID-related bulletin that we issued, which was Bulletin 20-05 back on March 6th, we simply asked carriers to encourage all their members to utilize telehealth services wherever appropriate, but we didn't include any formal directives or requirements. After that point, we maintained open communication with all the carriers as the pandemic progressed, and we advised them of any emerging issues that we saw. We were advised of a broad range of telehealth-related concerns from healthcare providers, consumers, and advocacy groups, and we communicated all those issues with the carriers. Naturally, we ensured the carriers were complying with existing law, but we also strongly encouraged the carriers to accommodate any reasonable provider and consumer requests that they were able to. And the response from the carriers across the board was extensive telehealth-related accommodations. Some of the first concerns we had were that there were limitations on the capacity and accessibility of existing telehealth platforms. Providers raised those concerns, and as soon as that federal guidance from the Office of Civil Rights was announced regarding the enforcement discretion for HIPAA privacy requirements, all the carriers expanded the systems that were eligible for telehealth coverage to include any of those non-public facing commercial applications, FaceTime, Skype, Zoom, things like that. We also received many requests from consumers and providers for broader coverage of the scope of services that would be available through telehealth. Carriers quickly responded here as well. They adopted policies specifically authorizing coverage for services such as applied behavioral analysis, physical therapy, speech therapy, and occupational therapy, which were not necessarily services that were considered suitable for telehealth pre-pandemic. Additionally, there was a very significant focus on expanding telehealth services for mental health and substance use disorder. I would say, though, the biggest and most impactful accommodation was probably the coverage of audio-only visits, which, as the commissioner mentions, they are specifically excluded under the Maryland statute that applies to commercial carriers. So the extent of coverage did vary by carrier, but all the carriers agreed to cover audio only in at least certain situations. We also received many requests to waive cost sharing for telehealth in order to encourage utilization and help increase social distancing and mitigate the spread of the virus. And all the carriers agreed to do this during the height of the pandemic. And then as we saw the utilization in telehealth increase, the providers then began expressing concerns about reimbursement levels, because traditionally telehealth was not typically reimbursed at the same level as in-person visits. Carriers then implemented policies that did provide for some reimbursement parity during the public health emergency. So the MIA continued to monitor market conditions and carrier actions throughout the summer and fall. And as the pandemic subsided, some of the voluntary accommodations were scaled back by the carriers. Most notably, the cost sharing waivers for telehealth began to expire in June and July. And at this point where we are now, all the carriers have reinstituted standard cost sharing for non-COVID related telehealth, except for one carrier who continues to waive the cost sharing for all telehealth, and a second carrier who is committed to waive cost sharing for mental health and substance use disorder telehealth through the end of the year. There's been various other accommodations that were scheduled to expire as the current period of the federal public health emergency was scheduled to end. But each time the public health emergency was extended, the carriers generally agreed to extend the accommodations further. So where we are now with this recent surge in COVID-19 cases that we're seeing and the associated spike in hospitalizations, we're monitoring the situation very closely, and we will be in frequent contact with the carriers to discuss their plans for addressing the surge. We'll also consider whether formal activation of any of our additional emergency powers is necessary. However, it is important to note that the telehealth accommodations we've discussed today, they were voluntary on the part of the carriers, and we currently lack the authority to require carriers to implement or continue most of these accommodations. And with that, I will turn it back over to the commissioner to discuss the lessons we've learned during the pandemic.
No, thank you, David, for that
Thank
thorough
you.
analysis. And I think it's clear from David's, presentation, what we've all seen here is the huge use of telehealth during the pandemic. And really the feedback has been overwhelmingly positive, particularly in terms of the ability to access mental health and substance use services in particular. If we look at the accommodations that carriers have made that have allowed people to continue to access care during the pandemic at times in which they wouldn't otherwise have been able to go to a doctor's office or to have a visit, we want to look at what it is that would have to, where legislation would have to be enacted at the state level. I'll talk about federal coordination in a second. It really is, the key issues are audio only consultations. I think we all learned that there's a role to be played for that. The compensation levels may be different. Suitability issues have to be considered. But what I think both carriers and patients and providers came to see is that there is a role for that. The other key issue has to do with provider reimbursement parity. When is it appropriate for services that are delivered through telehealth to be compensated at a rate that's similar? That is an issue that carriers made accommodations with. But that is not something they are required to do or continue. The cost sharing issues that David mentioned, again, the statute allows for cost sharing for telehealth services, even where they might not be allowed for other types of service, if that were an in-person service. Provider licensing issues, mandating coverage for telehealth for specific services. So there were some specialties or modalities where whether the statute itself would address, as some providers have requested, that it's clear that certain types of services have to be covered and would be considered by statute appropriate for telehealth. And then one of the areas where there continues to be disagreement between perhaps the provider community and the carrier community really has to do with coding standards, or at least a clearer understanding of what the covered services are and what the coding standards are for those services. And that, again, if there has not, the carrier community and the provider community have not reached an accord there. So that may be another issue that comes before this body as telehealth services are discussed during the session. One of the things that we've seen at the MIA is that telehealth has enormous capacity to improve access to healthcare, whether that's in the context of the pandemic right now or in the future, and frankly, to break down barriers for people who are challenged to access services for all kinds of reasons, and certainly to expand networks and deal with network adequacy issues. And we've recognized that in the draft revised network adequacy regulations that the MIA has posted for comment. And in our first public meeting, we will be very much focused on telehealth as we look at what role it has to play in network adequacy. But as others have said, one of the things that we feel is important, and obviously this body will have to consider, is what are the appropriate services and where is the infrastructure? So who actually has access to broadband? What are the kinds of tools that are appropriate, the software platforms, and what kind of technical expertise is needed? And with regard to tools and platforms, we have to be mindful that right now, the enormous flexibility that we've seen results from the fact that the enforcement of HIPAA has essentially, in some respects, been suspended with regard to telehealth services and certain platforms, and we don't know where that's going to go. Because in order to really effectively do what has been done during the pandemic, people have to have access to things like FaceTime and Skype and Zoom, et cetera, to meet with their doctors. And outside of continued revision or long-term revision to the enforcement standards, that would not be able to occur once those standards are no longer relaxed. And last point that I would make is that as we think about what to do in the context of private health insurance, is to be thoughtful about uniformity and consistency across different payers. So with respect to Medicaid, Medicare, the commercial insured market, and self-funded plans, the ability to try to be as uniform as possible obviously makes it much easier on providers, as well as individuals as they move from one payment platform to another. So with that, that is the MIA's presentation. And if there are any questions, we're happy to answer them.
One thing that does occur to me is that there probably are some symptoms that someone might need to consider, which can't be accessed that well using typical telehealth modalities. And I'm wondering, as you decide what's in and what's outside of what Maryland would want to have as in its menu, who is working on that end? Or maybe I'm not all that clear.
No, I think we understand what you say. I know that from the insurance administration standpoint, we look at it in a slightly different way than, say, for example, Medicaid does, because we look at it in the standpoint of if there are disputes or issues. Our experience has been that carriers have really been, at least at this point, quite broad in their review of what they think is appropriate for telehealth, at least in the context of the pandemic, and things that you might not initially think of as appropriate, like, for example, physical therapy. But the ability to use Zoom to help people move through a physical therapy routine have really been effective. But David may have more information, and I would expect the Medicaid folks to be able to speak to that.
Okay. All right. Well, that's probably sufficient for now, but there are accommodations that I know would need to be made. What about a person who's never been seen at all prior to a particular telehealth visit, and they have very complex symptoms? I mean, what can we do when some regulations are eventually developed to make sure that people for whom a televisit is not appropriate don't end up using up their insurance without any kind of substantial medical relief or analysis?
Madam Chair, from the health department's viewpoint, we would suggest that instead of looking at telehealth as kind of a finite pool by which you run out your insurance, that telehealth really is just the administrative enabling or provision of healthcare services. So from our viewpoint, a healthcare provider is providing healthcare at the end of the day. And it doesn't really matter from a healthcare standpoint whether they're doing it in front of a telephone, an iPhone, or in person, so long as they follow all federal and state laws and regulations. Obviously, from the carrier payment perspective, it matters quite a lot. But from a basic delivery of healthcare services, we're trying to make the administrative side of things as streamlined as possible.
Okay.
So we're working with
or would it matter if the healthcare provider is really at their kitchen table drinking coffee while their toddler is running around, but you're going to utilize your limited access to healthcare being seen under such circumstances?
Madam Chair, I think right now it really is a involving situation where we're almost 8 months into COVID. We're probably going to be dealing with COVID for at least 8 more months. And by the time we start emerging from hopefully widespread vaccination efforts next year, at that point, I think it really, we'll be able to have a much more detailed and useful conversation. I mean, right now we're all operating under states of emergencies. So it distorts any potential recommendations.
But there are regulations being worked on for telehealth services in the interim before we get to that point where things are more stable.
So Madam Chair, we would be happy to share with you what we're seeing at the national level, at least on the insurance side of things, to provide some views about, again, what is the definition of healthcare, telehealth, and when it's appropriate or not appropriate. We certainly see it as as Webster E does, as a modality, but we do appreciate your concerns about the potential for fraud or the potential for ineffective healthcare because you don't really have the opportunity. We know that carriers are evaluating when it is or is not appropriate, and claims can be denied by a carrier if this particular visit was not appropriate for telehealth, was not able really to be able to deliver the covered service in an effective way. And the MIA does then have the ability to review that and agree or disagree with the carrier's determination. But David and I will make it a point to go through and see what other states are doing. We meet on this with the MIA with the NAIC regularly, and we'll make sure that the committee has that information.
Okay, thank you.
Chair Kelly, Senator Kramer and
Yes, go ahead.
Senator Kramer and Senator Augustine have questions.
Sure. All right. Who's going first?
Senator Kramer.
Okay.
Thank you for that. Madam Chair, I just thought it was important to note, not a question, to note that it was the good work of the Finance Committee's own Senator Hershey that has afforded us this opportunity during the crisis to address many of these issues that are being discussed right now. So I wanted to commend Senator Hershey for having the foresight to introduce the legislation that we're discussing now. And it also goes to prove that just like that proverbial blind squirrel that occasionally can find a nut, that our Republican colleagues can from time to time come up with some good legislation. So
maybe you better remove your qualifiers.
Just thought I'd mention that and thank Senator Hershey.
Okay, I actually have a family member receiving telehealth services. So I just want to be sure as we go through the regulatory regime that we think of all of the bells and whistles as well as what's appropriate and what is not. I did have a constituent actually who got a call on the telephone from somebody that it turned out was just a scam artist telling about their telehealth services in her community and what they could do. And we found out there was nothing to it. The person wasn't a healthcare provider at all. And because it could happen so seamlessly without people's credentials or the known spot with a sign and the diplomas on the wall, some people, we've got to think through a lot as we do the regs, that's all. Okay, and Senator Augustine.
Thank you, Chair Kelly. Commissioner Bahrain, it's good to see you again. And I remain just really excited about working with you within the space of behavioral health. One of the things that you said that did give me a little bit of pause relates to telehealth as with network adequacy. I don't think that this telehealth, as Chair Kelly has been talking about, necessarily replaces some in-person services in a way that really deals with network adequacy. So I would hope that we are aware of that and perhaps making sure that we aren't going to allow these telehealth services, which are so important, to supersede the requirements for really in-person services across the state, which we are still lacking. I'm grateful that this is creating greater access, but we still got to keep up the work on the in-person access as well.
Well, thank you for that. Your comments are very well taken, and I completely agree with you. There may be some circumstances where telehealth can bridge some gaps, and we need to think about when telehealth is useful to open up and fill out networks. But you are absolutely correct that there are some things that telehealth cannot take the place of. We have a slightly more than a placeholder in our draft regulations on network adequacy. And what we very much want to do in our first public hearing on those regulations is address that specific topic. What role ought telehealth play in the measurement of adequacy? So thank you for that. And we are very aligned.
I look forward to participating in that. Thank you, Commissioners.
Okay, thank you. Thank you very much. Okay, seeing no other questions at this time, we'll go on to the next panel. The healthcare provider use of telehealth during the pandemic. Dr. Hasselfield from Hopkins, Dr. Croco from University of Maryland School of Medicine, and Dr. Truong from the Telemedicine Mobility Director at Kaiser Permanente.
Great, thank you. Madam Chair Kelly, Chair Gazzoni, and all the committee members, thank you so much for this opportunity to really come and speak about a very important topic, one that I'm living day in and day out. Much appreciate the time and again, the opportunity. We're gonna set the stage just for the journey for Johns Hopkins on the first slide. As an internist and pediatrician, I see both adults and children in one of our Baltimore City practices and have been living this care delivery for all ages for our Baltimore City residents throughout the pandemic. On our next slide, just brief disclosures, I do serve on an insurance plan here in Maryland and do have a small equity interest that does not affect this presentation. On our next slide, this is the Hopkins journey for telemedicine. We were less than 0.1% of total care delivered through telemedicine prior to the pandemic, about 50 to 80 total ambulatory visits in any given month. And you can see that on the bottom left-hand side. We hit over 90,000 in May, which was the peak, and began to trail off a little bit thereafter. But even going from 50 to 80 to still a run rate of 50,000 to 60,000 in August, September, October, still 1,000 times more telemedicine than we had prior to the pandemic. We've hit over 500,000 visits about 6 weeks ago, and we're closing in on 600,000 visits. That's covering over 250,000 patients, over 250,000 patients, averaging about 2.5 visits per patient, meaning many of our patients who are engaging in telemedicine care are coming back for another and another visit throughout these last few months. You can see in orange the breakout of our audio only, our telephone visits. That totals over 100,000 audio only visits underneath that near 600,000 total at this point, covering about 50,000 total unique patients. So about 2 audio only visits for unique patient that's undergone audio only care. Our audio only percentage was fairly high in March as we all learned together with our patients and our providers about how to rapidly transition. It was nearly 40%. And it's been 20% since about July, and it's slowly condensed to 19, then 18, then about 16 or 17% in October. But still, again, remains a meaningful amount of care, nearly 10,000 visits in October. You can see the week by week trend here on the right-hand side, just to see that it follows the same curve, and it really has been flat over the course of the last few months from about mid-August onwards. I will note that there's a small uptick for the first time in the week of November 9th, and the data from last week is further validating that we are in line with, unfortunately, the case shift of COVID in our own state and region, starting to see a slow uptick so far through Tuesday. I don't have our data yet for Wednesday. We're up over 10% for telemedicine this week, indicative of us transition backwards towards higher amounts of telemedicine. On the next slide, you'll see what this represents relative to our in-person volume. The blue line across the top was our total daily average in our fiscal year 20, which ran from July 1 to June 30th of July 1 of 19 to June 30th of 20. And you can see, and these are stacked together, that we had obviously a significant drop off in total ambulatory volume across the entire system in March and April. And the blue section, the telemedicine section, represented more than half of total ambulatory care throughout those months of March, April, and into May. Overall, since then, since that leveling off in August, it's been about 25% of what I call telehealth sensitive visits. When you take out lab and radiology and infusion, the things that are practically not telemedicine sensitive at this point, about a quarter of our care has been telemedicine. But in the bottom right-hand corner, just calling out that though every single department at Johns Hopkins Medicine engaged in telemedicine, some were well above average, and it won't surprise those on the call that mental and behavioral health remains 84% telemedicine in the month of October. But things like nutrition, newly able to broadly deliver telemedicine care under the expansion of codes during the public health emergency, has continued to engage in robust telemedicine care, but also our neurosciences. Both neurology and neurosurgery remain nearly half or slightly over half for neurology telemedicine, as our neurosurgeons engage in preoperative assessments, reviewing imaging and talking about surgical options, and evaluating post-surgical outcomes with patients, watching them move in their own home, a better evaluation of home environment mobility than coming into the office. Primary care remains high, obviously, and then certain areas of care, as we've highlighted, just aren't right for telemedicine. Eye exams aren't yet suitable. We're at ophthalmology at 0.3% telemedicine. But just to say, it's been broad and across all departments, and certainly varies within a department. And inside of any given department, there are clearly signs and symptoms that are not appropriate for telemedicine, but there are many things inside of any given department that are. As a primary care clinician, it has been extremely valuable for my adult patients to be able to have, there's no such thing anymore of, I forgot my medicines at home. It's my medicines are upstairs, and being able to do an in-home medication review and see their own home environment. And the same holds in pediatrics, to be able to evaluate for my young children with asthma. Let's walk through and identify common allergens in the home. Let's look at the carpet. Let's see the pets. Let's see how we interact in the home. It's all been beneficial in those areas to really be able to understand how certain home environment and social determinants play into healthcare. In our next slide, this is early data. This is the first time we've presented this data on a breakdown of the use of phone and video by certain social determinants and demographics. In the top bar, you'll see that, and this is by age of parent, obviously the younger children are representing the technology access and proficiency of the parents or guardians. But there's a breakdown of percent phone and percent video by different types of statistics. And I apologize if this is a little small. We're fitting a lot of data here on this page. But you can see in the top graph that our older patients have higher percentage of visits by telephone. Our overall system average through the pandemic is 20%. And you can see that our younger patients are below that average, all the way up to the age 50. And after the age 50, we're above the system average, with our over 75 patients being 2/3 video, 1/3 phone. When we look at it by language, our English speaking patients are by far the lowest phone percentage at 19%. And that's not surprising. Many technical platforms are predominantly displayed in English. Many also are displayed in Spanish, but few are displayed in other languages. We have invested in engaging interpreters onto our video visits, and actually in some areas, it's a benefit to execute telemedicine with interpreters, as an easier, we have 29 participants on this call right now. It is sometimes easier to bring a third participant into a video visit, such as an interpreter, than it is to try to allocate those resources into in-person buildings and in-person clinics. So we have seen benefits in that way, but it has required investment in virtually allocating our interpretive services. And on the bottom, we see a distribution by 4 key payer groups: commercial, Medicaid, Medicare, and our self-pay patients. And you can see just a very significant difference in the amount of phone usage in our commercial population, 11%, again, institutional average 20%, versus about 30% in the other 3 groups. Tech literacy, tech access, internet access, broadband access, as well as complexities in certain populations like adolescents who get certain amounts of privacy relative to their parents, as well as those with guardianship and cognitive limitations, all lead to different complexities in figuring out how to get the right technology to the right patient. But what this lesson clearly is showing us as an institution, that the importance of audio-only care, again, 100,000 visits and 50,000 unique patients, remains important as we think about ways to address technology access across our patient populations. We look forward to continuing to study more of these aspects with our Center for Public Health Equity and our Office of Diversity and Inclusion at Hopkins, who are making this a priority with us. On our next slide, we've invested for our patients. All patients learn differently, as we all do. We've published written instructions in multiple languages. We've published videos about how to engage in telemedicine, how to prepare for telemedicine. We've invested in a new centralized technical call center dedicated to telemedicine to help patients navigate all the complexities of the technology. And we've had to train Clinicians ranging from physicians to nurses to MAs to front desk staff, every member of the care team has added IT help desk to their job description, having to help patients navigate certain technical issues as we've engaged in this new expansion of care in telemedicine. On our next slide. Unique perhaps to some larger medical centers, but certainly accurate at Hopkins. It has allowed us to ensure continuity of care to patients who come to us from all around the region and country. We have delivered care to all 50 states during the pandemic through different waivers, both through telephone and video, as well as existing out-of-state licensure for our clinicians. That's been over 50,000 of those near 600,000 visits have been delivered to patients who live outside the states where Johns Hopkins Medicine has buildings, Maryland, obviously, Florida, where we have a children's hospital in the district. It's about 9% of our total volume. Nearly all of that is in our surrounding states, 85% in the 4 listed there. But it has permitted us to increase our reach to our patients during this trying time. On the next slide. It's not just about ambulatory care, however. We'll touch on just the inpatient setting very briefly as well. This is a screenshot of what our patients see on our bedside tablets. We've invested in and deployed tablets at the bedside in many of our hospitals, including all the beds in Johns Hopkins Hospital and Bayview in Baltimore City. It's allowed virtual rounding for clinicians to preserve PPE, remain safe, meet our teaching mission as a teaching institution to train the next generation of physicians, but not bring dozens and dozens of learners into our patient's room for risks of safety for both patient and learner. But with visitor restrictions, we've been able to more robustly engage family members and caregivers in care in a way that we never could before. When providers, like all patients, are facing restrictions on childcare, on exposures, the ability to deliver expert opinion virtually to our clinicians in the hospital from their home has increased workplace flexibility as well, where safe and appropriate. We've expanded our ability to monitor patients in a critical care setting because areas of Johns Hopkins Hospital in particular, which were never ICUs in the past, have now been COVID ICUs throughout the pandemic, and needing to enhance our ability to monitor remotely has been critical. Not listed here, but a program that we executed with Johns Hopkins Home Care Group and our School of Medicine pulmonary teams. We had 300 additional patients leave Johns Hopkins Hospital, Bayview, Howard County, Suburban, and Sibley, and enroll in home care monitoring with pulse oximetry, one form of remote patient monitoring, but allowed safer discharge for patients with a new disease, with a new respiratory disease, to have expert consultation with our pulmonologists, skilled nursing supervision, virtual supervision, as well as virtual pulse oximetry monitoring in the home. Of those near 300 patients, only 2 returned to the hospital. Another safe way to allow patients to transition out of our acute care settings when, unfortunately, our post-acute discharge options were also further limited, and helped expand those resources to those that needed them the most. On our next slide. It's always important to return to our patients. We've surveyed over 50,000 of those patients. They're rating their satisfaction with their providers 95 out of 100 on those encounters. We did a targeted survey to nearly 2,000 Johns Hopkins patients and got about 675 responses. When we asked them, would you recommend telemedicine to friends and family, the median response was 9 out of 10, with 10 out of 10 being extremely likely. And we asked them, how important would it be to have video visit options going forward after the pandemic? 88% responded moderate to extremely important to have that option going forward. And then on our final slide, just to echo what's been mentioned by our colleagues in the department and in the insurance industry, the flexibilities have been critical. We've listed some of the highlights here. These are the ones that I'm tracking on a daily basis for our office and for our institution. We've mentioned many of the Medicare, Medicaid enhancements, the telephone audio-only enhancements. I think I've hit on the importance of that for those 50,000 patients that have received care through that modality at Johns Hopkins Medicine. The national reach of Johns Hopkins Medicine has made it important for us to be able to operate under state-by-state waivers for licensure, and we're extremely appreciative of the flexibilities in our own state and in the District of Columbia. The number of codes that CMS permitted for telemedicine went from 103 to 238, and most recently to 249. This slide is just a few weeks out of date. But that expansion in codes means, as been mentioned, therapy, nutrition, speech language pathology, genetic counseling, a wide range of services that were more restricted previously that can be easily executed through telehealth were now permissible. And that includes the ability, as mentioned, with the Hospital Without Walls, or the Without Walls initiatives for many of our clinics is critically important. It decreases the flexibility of telemedicine to require the provider to be on site, so long as we implement specific professionalism standards, which we as an institution have. And then there has been flexibility in the HIPAA non-enforcement policy, although we are investing in and preparing for a transition back to a future state, and ensuring that no matter what, even if we use these platforms, our patients and the members of the insurance plans are always transparently informed about the types of platforms that we're using. Obviously, access to providers has been priority during the pandemic. So with that, I will end the presentation from the Hopkins side, and certainly will remain on for any questions.
Thank you very much. I don't see any hands raised at the moment. That was very informative. All right, we'll go on to Dr. Todd. Is this Croco?
Croco, yes.
Croco, okay.
Madam Chair, members of the committee, good afternoon. Thank you for the opportunity to speak with you today. My name is Todd Croco, and I am an emergency medicine physician by training, and I work for the University of Maryland School of Medicine. I'll be talking to you about telemedicine from the perspective of the University of Maryland Medical System. Next slide. It goes without saying that these are unprecedented times. And in order to rise to the challenges of these times, we as healthcare providers have had to adapt. And that adaptation has been made possible through several of the latitudes that have been afforded to us in the telemedicine space. On your slide right now is an example of the expansion and infrastructure that was seen within the Maryland medical system. On March 16th of this year, we performed 43 ambulatory telehealth visits. The medical system largely provided care in an in-person capacity. And if you consider March 16th as time zero as we entered into this pandemic, and then compare the amount of ambulatory telehealth services rendered over the last several months, approximately 10 days ago, we cleared the 230,000 patient mark. During that time, we also saw our no-show rates at approximately 23% back in March decrease to less than half of that since that time. Now, you might be wondering, how was this made possible? Why does this occur in the telehealth space? Next slide. And the answer is multifactorial. For patients, telehealth represents increased accessibility. They have fewer barriers around transportation. There's less need to leave work. It's less time consuming. By virtue of the fact that telehealth care can be rendered in a manner that fits into their calendars more easily, they have less wait times to get that care. And the care can be coordinated across primary care and specialty care. Additionally, it affords these patients the opportunity to stay local, less travel distance. It affords the provider the opportunity to make earlier diagnoses and implement earlier treatments. On the primary care and specialty side, it allows greater efficiency. They can reach broader sets of patients. They can coordinate their care among the different disciplines. And patients that in the past may not have shown will now still connect with their physicians, and it maintains that primary relationship. As you've heard already, many of these patients find it highly satisfactory to receive care in this capacity. Next slide. So who have we used telehealth to assist? The short answer is just about everybody. Telehealth has helped us overcome barriers in healthcare services. On the slide on your screen right now,
you see some demographic data that illustrates that many of the socioeconomic stress factors that affect our vulnerable populations apply to the full swath of our communities. It applies to the rural communities, the suburban communities, the urban communities. Many of these stress factors transcend all the different regions of our state. The challenges that our residents face universally include transportation and access to care and chronic disease management, pediatric care and maternal care. It is common throughout our various communities. Next slide. So I'd like to just share two particular examples of telehealth platforms that the Maryland medical system deployed during the course of the pandemic. The first is an emergency department teletriage service. This is an instance where patients meeting specific criteria would be initially assessed by the nurse upon presentation to an emergency department. They would be shown to a particular room where they would connect virtually with a remote emergency medicine physician. This decreased the exposure to the patient, to the provider. It decreased our personal protective equipment utilization. Recall in the earliest phases of this pandemic, getting PPE was a challenge for us across the country. And so this approach allowed us to mitigate that tension point. We have found that in this service, we have been able to see patients faster. In many instances, the patients can be evaluated and treated and discharged to home from that point, avoiding any further delay and further assessment in the larger emergency department with increased exposure risk. Another example is eConsult, a platform that we're building out and continue to expand upon within the medical system, wherein specialists and subspecialists can virtually connect to facilities throughout our medical system in order to assist with patient care and thereby avoiding secondary transfer to another facility. It promotes more rapid diagnosis, more rapid treatment, and less time consumption. Next slide. So you've heard many of these comments from the speakers prior to myself. We are simply advocating for parity in reimbursement, that is matching the in-person reimbursement with the care delivery that occurs through telehealth. You've heard about audio only, and we recognize that there are certain populations that may not have the technological equipment or the connectivity opportunities. And so in recognition of that simple fact, audio only remains an option for those individuals. And of course, the sustainability of the expanded locations that are eligible to receive telehealth would be another important sustainability project. Next slide. This is my final slide. At the federal level, we would like to advocate for continued expansion of the eligible practitioners. Of course, physicians and nurse practitioners were able to use telehealth prior, but during the course of the pandemic and the PHE waiver, we saw expansion into physical therapists and occupational therapists. And you've already heard from other speakers how that is imminently doable through the telehealth platform. Lastly, I'll just say that the EMTALA waiver has been incredibly helpful to us. In emergency departments where in-person requirements for medical screenings have been the way of the past, during this period of time that was waived in order to allow for virtual medical screening exams by qualified practitioners and patients for whom it was safe to do so. It made us more efficient. It helped us with wait times in the emergency departments, and it's proved invaluable from our operational perspective. Madam Chair, members of the committee, thank you for your time and attention today.
Thank you very much. It's getting more interesting all the time. Are there any questions? All right, I don't see any raised at this time. We'll move on to Dr. Dennis Truon.
Hello, hi.
Good afternoon. My name is Dennis Trong. I'm an emergency physician. Thank you, Madam Chair and members of the committee for having us on to tell our Kaiser Permanente story with telehealth and the pandemic. A little background about me. I'm actually I'm board certified in emergency medicine, a veteran for the U.S. Air Force, and been with Kaiser Permanente about 10 years. Helped create this telemedicine program about 7 years ago. I just hope to be able to tell our story, and I really appreciate all the insights given from the previous speakers. It's really great to hear from each other and learn. And I hope this take this opportunity to tell the story and hopefully inspire you to see how we can increase the tools in our toolbox to fight COVID. Next slide, please. So I'd like to just introduce another term that we actually use here in Kaiser Permanente is integrated telehealth. So we've been using this term since we started the telehealth program 7 years ago. So we started with the end in mind, and we really thought about, how do you take an integrated care delivery system and then use telehealth as an extension of the delivery system, all the people, the processes, the foundational electronic medical records, and use that integration in order to improve quality, access, efficiencies, care, coordination, and do it all virtually. So on the left here, you see that picture. It's probably a visual cliche. Everyone says, the patient's the center of everything we do. But we really took it to heart and made sure that we developed our telehealth around the patient, the patient, the family, the friends, and interweave that web of telehealth processes and technology throughout the whole care continuum on the right side, from home all the way to hospital. And we want to make sure that all this is integrated so you get the same providers, same processes, same ease of use technology on the same EMR backbone. So you don't have to worry about all the interoperability issues that occur with many different vendor services that piecemeal together. So what does a KP integrated telehealth look like? Next slide, please. So this is KP integrated telehealth. And basically, so we've been providing, like many other organizations, telehealth for decades, but that was really in the form of audio only or secure messaging. But since our inception 7 years ago, we just strategically and continuously connected the dots within our own system to consolidate and then implement and integrate the latest technologies to support the physician, the providers, basically allowing our system to provide the member with what we call a comprehensive integrated telehealth experience. So if you look at this picture here, just to provide some bearings, on the bottom is a patient entry, how they access care, either through our patient portal, kpi.org, clinical call center, or the healthcare team. On the top are all the numerous virtual care channels that are available to the patient. From left to right, there's self-service automation channels. There's asynchronous convenient options. And the right, there's your traditional synchronous video, text to patient, all those things. And in the middle, there's all the mobility platforms that we arm our physicians with. We have 1,500 physicians. All of them are equipped with a KP-issued secure laptop, KP-issued iPhone, KP-issued iPad, a home remote office for virtual. And with all those things, our physicians are able to collaborate daily. They text each other over 25,000 times a day, 1,500 physicians collaborating about care. The blue part of this graph are the parts that we consolidated over the years with my team as parts that we found that needed to be coordinated and integrated together in order to scale telehealth. So basically, a typical patient journey through this would be you're a Kaiser member, you're hurrying to get online for this Senate committee meeting, and suddenly you sprain your ankle for some reason. So you can't bear wait. You're on here on video, you're probably grimacing, putting on your best Zoom face you can, and you log on to your KP app under the phone, under your table here, and you can do a quick e-visit. So you submit a questionnaire about your sprained ankle. Within an hour, while I'm sitting here rambling away, you get a response from a physician. And because you can't walk, the physician said, well, let's offer you a video visit because we need to see and have a visual and a self-examination. So you get on video with us through our Kaiser Permanente app, not a separate app. A physician like me evaluates you, do our auto ankle rules, have you self-palpate and watch you on video and self-palpate based on these proven rules. And we say, well, you can't bear weight and you have some suspicious symptoms. We're going to order an X-ray for you. So I order the X-ray and I send you a secure text to that same phone that you were using for your Kaiser app earlier. And I say, well, once you get your X-ray in the Kaiser facility, and once you're done, sit in the waiting room or in your car, then text me back so I can look at the X-ray. You text me from the waiting room. I look at the x-ray, look through your EMR, your medical record, and I text you back, no fracture. I ordered you crutches and an ankle brace to pick up in the facility, some prescriptions for some Mega Motrin 800 milligrams to get in the facility. And then I email you your self-care instructions. And then I say, I instruct you to reply to me by email in 2 weeks if you're still not walking. Because if that's the case, I'm going to coordinate your care virtually to a face-to-face appointment with orthopedics and order any x-rays or MRIs that's needed. So basically you skipped an ER waiting room. There's no fragmentation of care. There's no risk of falling through the cracks trying to go from one vendor to a medical facility to a different pharmacy. And basically there's no having to go back to your primary care doctor to get an imaging order or having to drive around different places. That's what we really consider, our mission here is, with virtual care is to be able to, especially during COVID, be able to provide all that coordination virtually, but also have the ability to up triage you to face-to-face when it's needed. Each day, about 50% of our synchronous care is virtually, and if you add asynchronous care to it, over 70% of our physician provider touch points every day are virtual. Next slide, please. So along came COVID, and this is probably a year that most of us want to forget, but the silver lining is that while it produced a lot of chaos in the healthcare system, I think the healthcare system needed that kick in the butt per se. We had friends of mine that were in other organizations, other academic organizations that were not prepared with telehealth. And when COVID came around, they were scrambling to get their 1,000 physicians equipped, trained, acculturated to accept delivering care by telehealth, or spending an enormous amount of money white labeling with external vendors. We've been doing this for 7 years, so we've looked at it as an opportunity more than chaos. And basically, we stuck to our discipline rules of delivering on the value equation and putting the people first, the processes, then the technology to support those people and processes as we scaled our operations around COVID. Next slide, please. So first thing first, it always starts with the patient. So I always, with a lot of technology, you say you build it and patient will come. The reality is the technology should support the people and processes. We firmly believe that. So when COVID occurred, we made sure that you immediately educate the patient as quickly as possible through the patient portal, through our through the call center, through the healthcare team. So we made sure we made the patient understand the risk and benefits of a face-to-face appointment, how to do virtual. They haven't done many virtual visits, and all the benefits of that. And the fact that we can still, we're still one system. We can still up triage them as needed. So it helps them with guided decision-making along the whole way. I use it kind of synonymously to the Choose Your Own Adventure book when you're younger. Those Choose Your Own Adventure books, you read it and you can end up to the same conclusion many different ways. This allowed us to guide the member that they still have choice, but then yet we're guiding them to keep them safe and to keep our healthcare system resources practicing at the optimal level. So what's the telehealth impact? Next slide, please. So I feel very lucky. Our years of experience have allowed us to pretty much flip the switch to synchronous virtual care within a 2-week period. So pre-COVID, we were at 85% face-to-face, 15% virtual. And that's at a rhythm about 12,000 encounters a day. At March 9th, I remember I got the orders to say, well, we need to flip the switch now. We need to get everybody safe and flip to virtual care. So within 2 weeks, we've basically flipped on upside down, and 15% of our visits were face-to-face, 85% are virtual. In phase 2, we made a conscious effort to say, well, as a physician, if I can see the patient, it's so much more information than just audio. And it's a higher patient satisfier. We look at our survey results. So we really started pushing video first to our providers and physicians. And at one point, we got to 90% virtual, 10% face-to-face. And then now, for the past 5 months, we stabilized at about 50% virtual, 50% face-to-face. And of that 50% virtual, half of it is video, half of it is phone. So that comes out to about 85,000 video visits a month, 85,000 telephone visits a month. And we still have e-visits that come in about 50,000, and secure messaging, which is about 200,000. So there's a lot of virtual traffic that happens within our system that's all part of the care coordination and triaging of patients. Next slide, please. So As we move virtual forward, I mean, it's really important to look back at which providers are providing virtual care. And basically, we made it as part of the culture for the past 2 years. Every provider in every applicable department delivers both synchronous and asynchronous telehealth daily. So you're providing video visits, you're answering secure messages from your patients, all that. It allowed us to increase our video visits and sustain the increase of 1,400%. And you look at the top 10 departments, you have your bread and butter, primary care, acute care, and behavioral health, mental health, psychology, and psychiatry. 100% of our psychiatrists and psychologists are remote. 100%. So that's been important for us because we had some resource constraints within our DMV tri-jurisdictional area that we just didn't have enough psychiatrists or psychologists in certain areas. Once they all went remote, we were able to balance load across the whole region, the same psychiatrists, psychologists, because they were licensed in all 3 jurisdictions. And also, interestingly, with that balance load allowed better access, which allowed the highest patient satisfaction scores for our behavioral health department ever. So understanding that is really, even with the small departments, you have orthopedics, they're small department 1%, but 1% of 85,000 visits each month is still significant, especially for a department like ortho. Next slide, please. So I tend to use this term a lot. This quote, I love this quote. I've used it for as long as I can remember. Luck is when opportunity meets preparation. So we're here right now talking about how do we prepare our policies, how do we influence each other to prepare our healthcare system for the next wave or next pandemic, or whatever challenges come in the future. So if you look at, for us, the preparation would start with the patient, and the patient, educating them, but also getting constant feedback. So we've actually, while some healthcare systems decreased the amount of surveying they did with COVID, we actually upped the amount of survey. We wanted more feedback. And with that feedback, we found out we had the highest member patient satisfaction score in the history of our organization during COVID. We had the highest net promoter score online in the history of our organization during COVID. That just showed how the members, I think, are appreciative of the fact that we prepared and are meeting their needs appropriately. Our patient portal saw a 30% increase in patient use during COVID. Our Spanish-speaking patients saw a 1,000% increase during COVID. And that's because we made very intentional tweaks to make it Spanish-friendly, both from the interpreter services as well as for the language that is online. Our e-visits, which is asynchronous questionnaire care, went up over 500%. And it not only went up 500%, but with COVID, while we were trying to figure out as physicians, what would COVID entail and who to test, these e-visits has helped save about 100 FTEs of physician resources to reallocate for patient care, either face-to-face or other patient care avenues. Our synchronous virtual care, kind of the big topic at hand here, we saw our video visits go up 1,400%, phone visits went up 150%, and a text to patient, where I text my patients all the time, follow-up went up 300%. We instituted a bunch of COVID drive-throughs, drive-through influenza testing, and our telehealth asynchronous e-visits made up 1/3 of all of the drive-through and influenza testing. So that's hundreds of thousands of testing that was done self-service for my members. And another safety measure we had was pharmacy mail order and curbside pickup. It went up over 50% of our patients were getting mail order pharmacy. Both a convenient and safety aspect that's really been a great patient satisfier. Next slide, please. So thank you. I'd be free to take questions. Of course, I'll be staying on. I appreciate your time. Thank you.
Thank you very much. I don't see any questions right now, so we'll move to our final panel from the Maryland Healthcare Commission. Dr. Andrew Pollack, Ben Stefan, and David Sharp.
Thank you. Good afternoon, Chair Kelly, Vice Chair Feldman, Ranking Member Jennings, and members of the committee. Thank you for accommodating the Maryland Healthcare Commission today by allowing us to present later in your meeting so that we could complete the work of our regularly scheduled November meeting in advance. I also want to thank the members of this committee that also serve on the Executive Nominations Committee for your diligent work in considering the governor's nominations to our commission. The Healthcare Commission has promoted the adoption of telehealth for a number of years now. Over the past decade, however, the uptake of telehealth, as you've heard in prior presentations, has been slower than we would have hoped. This changed dramatically with the COVID-19 pandemic and with the establishment of the public health emergency. Use of telehealth increased dramatically in Maryland and across the country in late March and early April, as you heard. Clinicians and patients were quick to respond to the fact that a telehealth visit was often the only option to keep patients and providers safe. Nationally and in Maryland, decreases in in-person care were offset partially by rapid increases in virtual care, particularly for specific specialties such as psychiatry. At the peak of the pandemic surge in April, approximately 50% of primary care visits for Medicare beneficiaries in Maryland were delivered via telehealth. Statistics reported by the Assistant Secretary for Program Evaluation at the U.S. Department of Health and Human Services and confirmed by our own analyses showed that Maryland ranked among the top 20% of states in the share of primary care visits delivered to Medicare beneficiaries via telehealth. That's compared to the situation prior to the pandemic, when Maryland ranked in the bottom 20% of all states. Proactive policy changes by payers supported and encouraged the rapid adoption of telehealth during the pandemic. Prior to the pandemic, Medicare and Medicaid were very prescriptive in defining how telehealth could be used, the settings of care, the geographic areas where telehealth services could be delivered, and the types of clinicians that could deliver virtual care. During the pandemic, many requirements were relaxed or eliminated. Medicare and Medicaid expanded eligible clinicians, extended delivery modalities, and increased the permitted locations of care. Many private payers made similar changes. The decisions made by the U.S. Department of Health and Human Services at the end of March to allow clinicians to use widely available communications apps, such as FaceTime and Skype, helped foster the rapid adoption of telehealth. Since the end of the first surge in June, use of telehealth has declined somewhat, as you saw in prior presentations. But telehealth utilization is still well above pre-pandemic levels. Many clinicians expect that reliance on telehealth will diminish after the public health emergency, but that nonetheless, it'll remain higher than it was pre-pandemic. Important challenges must be addressed if telehealth is going to expand after the public health emergency ends. The federal government must take the lead in resolving many of the access and reimbursement challenges that exist. The federal government has signaled that it'll make permanent some, but not all, of the waivers made to Medicare payment rules and to HIPAA requirements. There's also work for Maryland to do, including adopting interstate compacts for some non-physician practitioners and definitively addressing the question of payment parity for telehealth services. More progress is needed on the systems that support clinical practices and health systems. Clinician workflow must change to accommodate virtual visits, and clinicians need to develop skills to assess patients who are not physically present and to decide when a patient must be physically present for evaluation. We don't believe that those decisions can be made through a regulatory structure. They have to be made by the physician in the face of in the presence of the patient. We don't attempt to regulate a physician exam when the patient is present in the office. It's not rational to regulate what type of exam the physician must do by determining what type of service will be covered by telehealth and what won't. Electronic health records and practice management systems must evolve to capture unique clinical and administrative aspects of a telehealth visit. Telehealth has shown its great promise over the last 8 months, but structured evaluations are needed to determine effectiveness and the impact of telehealth on cost and utilization across conditions, settings, and provider types. Proponents have argued that telehealth consultations generally produce either better outcomes or no difference when compared to in-person interactions, given similar settings and clinical indications. The rapid growth in the use of telehealth during the past few months could provide the basis for more comprehensive assessments. I want to comment on two concerns that I heard in some of the prior presentations. One relates to the reimbursement levels for telehealth visits, and the second relates to broadband access on the part of patients. So with regard to reimbursement issues, when we consider how to reimburse telehealth visits, it's important to remember that if a provider is going to spend 15 minutes with a patient in the office or 15 minutes with a patient over the phone, that's the same 15 minutes to the provider. It costs the provider 15 minutes of his or her time, regardless of the platform through which the visit occurs, in-person versus telehealth. From the patient's perspective, however, that 15 minutes is just 15 minutes. It doesn't involve getting in the car and driving to the office, during a pandemic, it doesn't involve exposing oneself to the other patients and the other people in the office and potentially becoming infected. And it doesn't involve driving home. It doesn't involve taking a day off of work. It's dramatically less expensive to the patient and essentially the same cost to the provider, the same 15 minutes. Reimbursing it at a dramatically different level doesn't make sense. All that does is encourage the provider to schedule an in-person visit as opposed to a telehealth visit. The second thing that I heard in some of the other presentations was concern about the need for broadband access in order for patients to take advantage of these telehealth options. And many of the platforms through which the telehealth services are being delivered right now use simply cell service. Patients see their providers on their smartphone. All it requires is a smartphone with video capability. The apps that are being used right now initially included things like FaceTime and Skype that presented some HIPAA challenges, but Doximity and others available right now are very easy for patients to access. They don't need to download software. They just click a link that's sent to them by their provider on the phone, and they have immediate access. So many of the technical challenges have been overcome and in light speed as a result of the pandemic. I've asked David Sharp to provide an overview to the committee on the steps that the commission has taken to advance telehealth in the state. Following David's presentation, Ben Steffen will have comments on directions for future reimbursement of telehealth services.
Thank you very much. Are there questions? Okay, then we'll go on to David Sharp.
Good afternoon, Madam Chair, members of the committee. Thank you, Dr. Pollack, for the introduction. It's my pleasure to be here to talk to you all today. Just for the record, I'm the director for the Center of Health Information Technology and Innovative Care here at the Maryland Healthcare Commission. Let's advance the slide, please. So wanted to give you all just a high-level glimpse of looking at Medicare data on the telehealth visits per thousand. And what you're seeing on this table is the top 10 states. It's organized by calendar year 2020. And what we're comparing is the first 6 months of 2019 and 2020, and looking at the visits. And what you can see is on a per thousand basis, if you were to look down to row 7 or count 7, in the first 6 months, the average per thousand in 2019 was about 5. And you can look where it has ended up in the first 6 months of 2020. So quite a difference. I think we're hearing, this just reaffirms what we've heard from a lot of the prior panelists, that telehealth has skyrocketed, and as noted by our chairman, Dr. Pollack, equally as well. Let's go on, please. Next slide. Okay, in April, MHCC launched a telehealth virtual resource center webpage to help educate and provide resources to providers implementing telehealth. The webpage features more than 30 items. It also contains several web-based tools, such as the Telehealth Readiness Assessment Tool, which has received about 2,500 hits since April, and a telehealth technology vendor portfolio that includes over 75 vendors with information on HIPAA compliance, business associate requirements, and vendor use ratings. We continue to add information to the webpage to increase awareness and promote effective use of telehealth. Next slide, please. The consumer telehealth webpage contains about 20 resource items aimed at building consumer education and awareness, such as information-based flyers, podcasts, PSAs, and links to national resources. Consumer awareness expansion initiatives are ongoing. It's worth noting that since April, staff has responded to more than 100 inquiries related to telehealth. Next slide, please. Since 2014, MHCC has awarded 17 telehealth grants to qualified healthcare organizations operating in Maryland. Lessons learned from grantees inform future telehealth initiatives. In April of this year, the MHCC awarded 3 state-designated management services organizations a grant to diffuse telehealth in practices. The MSOs are targeting practices that are reluctant to adopt telehealth technology absent technical support. The grants provide MSOs with milestone payments for assisting practices to complete a telehealth readiness assessment and address gaps, restructuring workflows, educating on payer use policies, and providing staff training on the technology. Next slide, please. Staff invited stakeholders to participate in a telehealth policy work group to review policies temporarily implemented in response to COVID-19, identify policies that ought to continue after the public health emergency ends, assess stakeholder plans to introduce telehealth legislation in the upcoming session, and consider opportunities for stakeholders to collaborate on future telehealth legislation. During the initial meeting, the work group discussed key telehealth policy changes implemented in response to the public health emergency. In the second and third meeting, the work group deliberated on the benefits, unintended consequences, and permanency concerns related to key policy focus areas shown at the bottom of this slide. Next slide, please. Included on this slide are other key policy focus areas the work group will review in subsequent meetings. We anticipate that the work group activities will conclude in January, and an information brief highlighting key takeaways from the work group is targeted for release in 2021. Next slide, please. Oh, I'm sorry, can you back up one slide? I think we went too far, too fast. Thank you. The MHCC is planning to conduct an assessment of telehealth in 2021 to better understand the impact of telehealth on assessing access to care, leading professional services delivered using telehealth, whether telehealth has created new demands or is a replacement to in-person care, as well as its effect on emergency department utilization and hospital readmission, among other things. So we can advance the slides. So Madam Chair, members of the committee, this concludes my portion of the presentation, and I will now turn it over to our Executive Director, Ben Steffen.
Let me see, I think there might be a question. Did Chairman Griffith have a question? Okay, but we'll move on.
Good, still listening.
Okay.
Chair Kelly, members of the committee, Ben Steffen, Executive Director of the Healthcare Commission. I'm pivoting a little bit away from what I had planned to say to really emphasize how impressed I was with the presentations by our own Dr. Pollack and Drs. Hasselfeld, Dr. Krakow, and Dr. Trong, because really what they said is what I would, from a layman's perspective, really emphasize, that telehealth offers us an opportunity to accelerate the development of an overall consumer integrated front door for the delivery of healthcare. And they've shown us how, each in a unique way, how that could be delivered, and really taking us beyond what most people think of today, which is I had a telehealth visit, but really to put a whole set of different telephonic tools and technologies in place to really change the way that healthcare is delivered. We saw that clearly with Kaiser. I think that can be transported, but the big challenge will be how do we elevate that, or how do we translate that to the practices in Maryland that are neither the size, scale, or have the funding capabilities of either of Kaiser, Hopkins, or the University of Maryland. They also pointed out an important element, I think, that we need to segment patient populations. For example, the healthcare needs of a diabetic patient versus a patient with behavioral health needs are going to be vastly different. And the telehealth requirements that would support that patient are significantly varied. We also need to move beyond thinking about it simply interactions with the provider, but also consider how we integrate home-based treatment and monitoring equipment into the care of a patient with a chronic condition or an acute condition that can be treated from within that patient's home. Thirdly, we need to think about how we build the capabilities of the provider workforce, something that Dr. Pollack talked about, to support telehealth care. It's not simply a pivot. It does require, as the providers emphasize, training and workflow modernization, development of new and different scheduling systems, and ongoing continuing education regarding best practices for telehealth. And then we need to think about working with payers as to how we align benefit structures and rearrange physician incentives in order to make the technology fully supportable in the practice environments we have today. Fourth, we need to aggressively measure the value of healthcare delivered through telehealth by quantifying clinical outcomes, assessing improvements in care, measuring provider satisfaction, not just in the pandemic, but on an ongoing basis. And we have to use that to advocate for continued expansion and evolution of what this mode of care really means. And lastly, we need to think about what telehealth can really do to provide an opportunity to expand coverage. We all know what young Invincible's sense of their need for care is, but telehealth does provide an opportunity to engage populations in their healthcare in ways that we can't through existing models, and we need to think about that in collaboration with our payers, colleagues, in developing new coverage models that really offer affordable options for populations that for either because of affordability or choice have not acquired health insurance up to this point. So thinking across all the dimensions, what those four presentations really outline to us is how do we transplant what they described, exciting elements of a new model of healthcare into community practices across the state where approximately 45 to 50% of physicians and other clinicians now practice. That's our big challenge.
Well, a lot of interesting developments and some challenges, and I'm sure you at the department are working on systematizing in writing or in print what you think works well and what you think needs to be changed. And at our level, and maybe in the subcommittee that Senator Griffith chairs, we've got to think about regulations. You're making us somewhat smarter. And now that we've met some of you guys in person, we hope you'll take our calls when we're working on any statutory changes that we will need in order to make this all work well.
We will be delighted to take your calls at any time.
Okay. Any other questions or comments, colleagues?
No, Madam Chair, just thank you for including us in this hearing. And as you know, many of us, building on the important work that was done last session, have continued to work this interim on this issue, which impacts all of those of us that are in physician shortage and medically underserved areas, whether we're in the cities or whether we're in the counties. And so we'll be doing some work with some of our colleagues on the Senate Finance Committee to get a piece of legislation that addresses some of the concerns that have been pointed.
Fantastic. And I did hear several panels back, the social determinants of health coming up. And that's something that I know is important to many of us.
Yes, ma'am.
I want to thank our staff for coordinating, and Tammy and Patrick, and to thank all of you for your interest, and all of the presenters for making us smarter and making us more aware of what you're doing, the changes that in some degree we may not have been as aware of as we should be. And to thank everybody for having a safe and a good Thanksgiving, and don't do anything that would cause you to get COVID. Thanks so much, everybody.
Thank you.
Thank you, Madam Chair.
Thank you, Madam Chair.